Good morning, sir. Good morning, both the secretaries, state and branch.
Yes, yes.
And good morning to all our speakers.
Yeah, good morning, Dr. Awad.
Dr. Arun Shah, sir, Dr. Joy, sir, Dr. Shabria, Manish Shabria, sir, Ashutosh.
Good morning.
Good morning.
Good morning, everyone.
Good morning, everybody. Good morning.
Yeah, people have started joining.
Yeah, I think he has made it live. Yeah, YouTube, yeah, they're open.
Yeah, we'll wait for 2-3 minutes because
Yes,
people
yeah.
are joining.
I'll just go and get some water. Yeah.
Good morning, Dr. Preeti Chabaria.
Good morning, Dr. Shah.
Yeah, good morning.
Good morning, sir.
Good morning.
क्या सर आपकी थोड़ा इल्यूमिनेशन ज्यादा होता है तो अच्छा है ये थोड़े आप
I know I'm trying, but it's not working out. I realized it.
you are not seen
I just try, but if I do the other light, then I become dark.
yeah.
Don't worry, you will see Dr. Chabria's illuminance on in knowledge.
Yeah, light, yeah.
When you deliver lecture, don't worry.
That makes me more dark.
Yes, because of the light, yeah.
There are around 2,207 participants now. Still wait for about
More than 800 registrations. So,
Yeah, I know.
yes.
It means so many are worried about Alzheimer.
We are going to increase your worry, not reduce it. No, Joy?
They have got Alzheimer's.
No, we'll give you way out.
Yes.
I am going to share
Definitely.
with you the 10 commandments for Alzheimer prevention. So,
Okay, I think I succeeded in improving it, right? Yeah.
Yes, now you are seen, sir. Yes.
Yes, better.
yeah, so your light is better now. I was just about to tell you
Yeah,
that.
no,
Dr. Desai,
that's my spot is usually a
Dr.
problem.
Desai, your name itself includes joy.
Yeah.
So that is joy of life. So no Alzheimer in such patients. When you have joy, no Alzheimer.
बात कर ले नीचे वड़ थोड़ो
Yeah, 231, 232, 33, 35, 36.
I think we can start, Dr. Girishlar,
Okay.
because we are already online.
Yes.
I start with permission of the State Secretary and our branch president. Yeah, good morning, everybody in capacity of. Good morning, everybody in capacity of Secretary IMA Mumbai branch. I welcome you all for this World Alzheimer Day webinar, which is a topic little hatke because we have always come across so many topics, but this is a very important burning issue of society today. And so we are very lucky to have Dr. Arun Shah and his team to elaborate on such a topic. Now, see, Almighty has given us two qualities. One is to remember, one is to forget. We were ideally supposed to use that quality to remember Almighty, His grace, His state of omnipotent, omniscient, whatever, and forget the mishaps in life so that we can sail through better and with joy. But unfortunately, we always try to remember what good we have done to others and what others have done back to us. And we try to forget what others have done good to us and what bad we have done to others. So I think if we just turn the terminals, life will become very happy and successful in all the ways. Now today, we are going to utilize this quality of memory and forgetfulness. So we'll forget all the myths which we must have come across as far as Alzheimer is concerned. And now we will have develop our memory and remember whatever knowledge we will gain from Dr. Arun Shah, Dr. Desai and the team. So now I request Dr. Jitesh Mehta, our president, to address the August gathering.
Thank you, Dr. Girish Lad, and a very good morning to all of you. As Dr. Girish Lad rightly said, this is one topic which is very rarely discussed. And so when we came across this World Alzheimer's Day, of course, 2 days later, and we got this opportunity to tie up with HN. And of course, Dr. Arun Shah sir was very kind to give us this whole program and chart out this whole program. It looks very interesting. I'm sure we'll all learn a lot from today's CME. Friends, just a brief reminder that next Sunday also we are going to have a big program on a big way. We are going to celebrate the World Heart Day. It is, I think, on the 27th. And so that Sunday also we are having a full team of cardiologists who will be talking to us on various topics. It will be a marathon program. So don't miss getting registered on that. You'll get everything in due time. IMA Mumbai branch does all activities like Aao Chale and blood donation. So we are going to have another blood donation camp in the next month. Most probably we'll be doing a blood donation camp almost every month. So we have funds and we are going to utilize them in the right way. So friend, I always, it's my honest to always motivate people to become members of IMA Mumbai branch. That's why I request all of you, I implore all of you to please, those who have not become members and those who are members and whose friends are not members, please keep your eyes and ears open. If you come across any new doctor, any new person, please make them members of IMA Mumbai branch. Because as Dr. Pankaj Bandarkar, our state secretary, will agree that IMA Mumbai branch, I mean IMA for that matter is one of the only bodies which can fight for the welfare of the doctors at the state, at the center. If some new laws come and we always have to be very alert and we have to be a strong body. And IMA branch is, IMA is a one association which is spread all over the country. That is one thing which is very important. We must keep on increasing our membership strength. I think with these few words, I will hand over the mic to Dr. Anila to do the further proceedings. Thank you very much.
Thank you, Dr. Jitesh. I was just looking for a presentation of why to become a member of IMA, but I could not load it. Anyway, we'll do it in the during the session. Friends, today we are just starting the seminar on this Alzheimer disease, and the first topic, of course, is the basics of dementia. Everyone knows that dementia and Alzheimer are closely associated. Around 46 million people worldwide are suffering from dementia, and it is expected to rise 130 million by 2050. So to talk on this very important issue, we have a stalwart in this field, and Dr. Arun Shah. He is the director of neurosciences in HN. And to introduce Dr. Arun Shah, I request Dr. Usha Shah, the Assistant Director, IMA CGP, Mumbai branch. Dr. Usha Shah.
Yeah, thank you, Dr. Anil Awad. It's my great privilege to introduce such an eminent personality in the field of neurosciences. Dr. Arun B. Shah is a consultant neurologist and PG teacher and director of the Department of Neurosciences at Sir H.N. Reliance Foundation Hospital and Research Center. He completed his MBBS from St. G.S. Medical College, Mumbai, and was awarded gold medal. He then completed his MD in internal medicine and DM neurology at the same institution. He completed a fellowship in cardiovascular disease and stroke at the Oregon Health Sciences University, Portland, Oregon, USA. He was professor and head of the Department of Neurology at TN Medical College and Nair Hospital in Mumbai, and has trained and mentored several postgraduate students. He has been in clinical practice for 30 years with special interest in stroke, dementia, and neurocritical care. He was the first neurologist in Mumbai to use reperfusion therapy in acute stroke in 2002 and presented his data on thrombolytic therapy of acute stroke in India at the World Congress of Neurology meeting held in Sydney, Australia in 2006. He is actively involved in clinical research in the field of stroke, dementia, and Parkinson's disease, and has delivered several lectures at various meetings. Dr. Shah directs acute stroke program at Stroke Ready Sir H.N. Reliance Foundation Hospital with stroke clinic for the young and offers holistic care to patients at the multiple sclerosis clinic, including latest disease modifying therapy. Today, he will be talking on basics of dementia. Welcome, sir. Over
Thank
to
you.
Dr. Arucha.
Thank you. I'll just share my screen. So good morning to everyone, friends, and I must thank Dr. Jitesh Mehta, Dr. Anil Hawat, Dr. Lad, and Dr. Usha Shah for making this possible. And this is, of course, being done on because September is the month of dementia or Alzheimer's disease, as we call it. And not, of course, they're not synonymous, and that we'll see as we go through my presentation. And 21st September is World Alzheimer's Day. We could not keep on 21st because being a Sunday, it would be better to keep on a day when many people can get benefit out of the presentation. It is basically to increase awareness of the burning problem in society, as was mentioned by Dr. Jitesh Mehta. Now, I'm going to take 30 minutes basically so that my colleagues can go forward and talk more about this here. So I thought I'll just discuss the basics. Let's see how I can present this.
There's a screen icon at the top.
Yeah, no, I'm just saying that it was hidden there. So, okay. Yeah. So I can just take a second to hide this, there are too many things going on. So the first depiction was, of course, interesting to see that what happens in the brain is what happens in the trees. As the tree grows old, the leaves dried up, and the same thing will happen in our brain. And when it goes to the extent when it's seen here, then we probably are seeing for trouble. And that's what I think whole concept has been on relation to dementia. Now, what is the definition of dementia? This is what I think the slide, which tells you that there is impairment in two cognitive domains, at least more than two cognitive domains. It should be declined from a previous level of functioning, and it should interfere, means there is a functional impairment. And of course, your workup shows that there is no better explanation by any other disease process or psychiatric problem, or for that matter, any metabolic problem. When you have all these conditions complied, then we use the term dementia, which is, as we saw here, is an umbrella term. a general term, does not tell us about the cause. Now, what happens with aging? And now there is a normal aging process. When we lose some amount of brain functions, like retrieval becomes slow, the processing becomes slow after the age of 60, 65. However, you are functionally independent. Then at some middle stage, of course, is mild cognitive impairment, where there is some impairment of one particular function of the cognitive domain. However, person functions independently normally, and that is then we classify him as mild cognitive impairment. And then the next stage, of course, is dementia, as shown here. So what are the criteria for diagnosis dementia? It has to be declined from previous level of functioning. So a person who is mentally challenged or mentally retarded since childhood, he is not a dementia. He is mentally challenged, right? So there has to be decline from previous level of functioning. There is impaired function at work or usual activities. A person cannot carry out his probably activities. It is not explained by a delirium or a psychiatric disorder. And detection and diagnosis of dementia mainly depends on history from patient and a reliable informant. And of course, that is followed by detailed examination when we do bedside mental status examination, or in certain cases, probably required is neuropsychological testing. And then dementia criteria, what the definition is, what are the cognitive domains which are gone. So at least two of these should go for us to call dementia. There is impaired ability to acquire or recall new formation of memory, that is memory impairment, or it could have poor judgment or executive functioning, or there is impairment of visuospatial functioning, like finding out ways or dressing, trouble recognizing objects, or probably mapping a route when you want to go out. Or you could have impairment of language functions, like trouble finding words, errors in spelling, and trouble reading. And finally, you may have what is known as behavior and psychiatric aspect. That means there is a change in personality and behavior, which includes apathy, social withdrawal, agitation, compulsive behavior, and so sometimes socially inappropriate behavior. So any two of these are required to say diagnose dementia. Now, as you said, dementia is an umbrella term. And what are the underlying disease processes? So this schematic or cartoon diagram just shows you that almost 50 to 75%, depending on the series you take, are probably due to Alzheimer's disease, which is the commonest cause of dementia and senile dementia. Then you have vascular dementia, almost 20 to 30%. And then there is a concept now of mixed dementia, that you have pathology, you have Alzheimer's pathology, plus you have vascular factors going on. And then there's a double whammy, which gives you more of a dementia. So in India and Mumbai, particularly, our study showed that mixed dementia is pretty frequent, and Alzheimer's may not be that frequent or probably almost equal. Then Lewy body dementia is a rare variety of dementia you should know about. And of course, the frontotemporal dementia, which is a rarer variety, but it is important to recognize this. It starts at a younger age, and with usually almost 40% will have positive family history. So this is just a brief introduction, and we'll go on to why do we care about dementia? So it appears that G7, G8 people not only discuss health, but economics, but they also discuss health. And so in 2013, G8 stated that dementia should be made a global priority, and their ambition that a cure for disease-modifying therapy should be available by 2025. We are in 2021. Some things are in sight, but nothing which is concrete at the moment. 1 in 3 seniors dies with dementia, and Alzheimer's disease, as I mentioned, is almost responsible for 60% of dementia. And if you take the age prevalence, and you take a person with 65, 3% to 11% among them will have dementia, or maybe Alzheimer's, some of them. And at the age of 85, that is almost chance that 4 out of 10 will have dementia. So look at the problem which we face is tremendous. In India, of course, things are changing. As you know, the age longevity is increasing, life expectancy is increasing every year, and by 45, 50, it should be 75 years or so. So with that, if you see at 2015, you have about 9% of population above the age of 60, while at 2050, it will be almost 20%. And this is bound to result in increase, and while you may have more than 1 crore or 33 lakh people with dementia by the age of, by 2025. So that means it's a problem. And there's the same graph which shows that at 2020, you have about 4 million patients with dementia in worldwide, and it has almost gone to almost 13 million by 50. So, but there's this very important point I wanted to make in this slide is before you diagnose dementia, you must rule out treatable condition or reversible encephalopathy or reversible cause of dementia. And these are some of the reversible causes started, not all of them here. And probably right from chronic meningitis to subdural hematoma to alcohol to brain tumor, normal pressure hydrocephalus, hypothyroidism, B12 deficiency, autoimmune encephalopathies, drugs, and depression. There's a big factor of this, and this probably, I think Dr. Preeti Chabria will be covering some of this issue, and of course, in the panel discussion, Dr. Ashutosh Shah will discuss about this part. What are the risk factors for dementia? As all the risk factors which are for vessels or vascular disease are risk factors for dementia. Dementia is much more common in female than in male. ApoE for genotyping, which we'll deal with in future, also is one of the risk factors. So genetic factors. Then probably age is the most important factor. But the whole is aging process. Stress, Down syndrome people are more prone to develop Alzheimer's dementia. History of head injury, and of course, the vascular risk factors, as I mentioned, are one of the factors which can lead to dementia. So what is important is to remember is modifiable risk factors. Out of all the risk factors we mentioned, if you eliminate one of these 7 would lead to almost 30% reduction in the incidence of dementia. That is obesity, physical inactivity, mental inactivity, depression, smoking, low education, and of course, certain dietary changes probably are responsible for, and correction of all this probably will lead to reduction in population incidence of dementia by almost 30%. And that's a very important factor. And I think Dr. Joy Desai is going to discuss about sleep, which I have not mentioned here. So how does our knowledge about dementia comes from? And this one of the important study, which is a non-study, which is I think this is the Time magazine poster, the prime publication where this was covered, and where they have probably studied the nuns, almost 780 nuns who have been studied from 1986 onwards. That is for the last 35 years, and their brains are also being studied, and their cognitive things are being, and the personality and life expectancy is being studied. And what we learn, there are various new concepts coming out of this study every year. What we have learned up till now, that those study of schools of sisters showed that the low linguistic ability in the early life, that is low idea density and low grammatical complexity in autobiographical essays, was associated with the development of Alzheimer's disease neuropathology, but not cerebrovascular disease. So this is what the concept of education and the risk of dementia comes from. And in addition, that if you had associated vascular disease in the brain, in people, nuns who had associated evidence of vascular disease probably had more likely to develop clinical dementia than those who did not have. So this again emphasizes the points we made in the risk factors. Now, this is just a typical story which we see clinically. This is taken from some of the training modules. There is an 80-year-old man admitted to the hospital for pneumonia. He develops what nurses describe as sundowning behavior that includes nighttime disorientation and some mind agitation. And his wife says he's not like this at home. So he suddenly changed while going in the hospitalization. He went only for pneumonia and not for neurological problem. And this is very common we see in our clinical practice. During morning rounds, he's pleasant and answers questions appropriately, except he forgets why he is in the hospital. His examination and neurological examination is normal, except for the pneumonia, which was evident. And he's not able to say the days of the week backwards. That means his attention span is reduced. So what is most likely? Is it delirium or is it dementia? I think it is most likely Alzheimer's disease, which gets uncovered when a person goes to an unfamiliar atmosphere and is very commonly observed and very commonly diagnosed. So what are the early signs of dementia? Memory loss, difficulty performing familiar tasks, disorientation in time, place, poor or decreased judgment, changes in mind, personality and behavior, problems with imaging spatial awareness, misplacing things, withdrawal from social activities, problems with language and communications, difficulty in planning and solving problems. And so these are all very common presentations of early signs of dementia, and any of we observe, we should be aware of it and then we require a detailed workup. And this is the more detail of symptomatology. There is episodic memory loss, visuospatial, the language difficulties, some of the dementias, which are particularly posterior parietal atrophies, and people who have dominant hemisphere posterior parietal atrophy may present only with language and their memory may remain intact. Then executive functioning impairment, the problems with calculations, difficulty using devices, learning new technologies. You bought a new iPhone and you don't know, you don't learn how to operate it, disorientation in time, place. Then most important is BPSTs, behavioral psychiatric manifestations, and that can include a range of disorders like depression, apathy, anxiety, irritability, agitation, poor simple control, delusion, hallucinations, change in personality, new hobbies or interests, obsessive compulsive behaviors, loss of empathy, disinhibition, and poor hygiene. How do you assess dementia? I got lost one more. I think the important is rarely you have motor manifestations of dementia, restless behavior, muscle weakness, poor imbalance while falls, problem using hands and feet, incoordination, tremor, muscle cramps, sleep disorder, snoring, loud snoring, gasping for air, dream and enactment behavior, or what is called a rampant behavior disorder. And general symptoms start as the dementia advances: weight loss, change in eating behavior, positional dizziness, bladder and bowel incontinence, and sexual dysfunction. So these are the range of symptoms which Alzheimer's disease can produce from various stages, from stage 1 to stage 3. So when you see a person with dementia, what we are supposed to do? So do you require pre-diagnosis of dementia, or what was the person like before? Cognitive assessment, then assess their functional ability, assess their behavior, and then decide what kind of care he requires. And this is how one should go about in every patient. So you should risk factor assessment, whether person has hypertension, diabetes, what was their medical history, go through their labs, which is routinely done. I think I don't have to tell this August gathering about this. And then of course, we should see early warning signs like depression, gait disorder, and frailty. Cognitive assessment in bedside can be done in a very simple way. I think, and there are two things. One is, of course, the informant 8-item ascertained dementia tool available. And then, of course, you do a mini cog. Mini cog is few minutes that, and it will probably very easily can be carried out by just in the bedside. And 8-item informant dementia tool is this. This is the this is a paper where you can charge yes or no, and if you give more than 2 yes, then probably person has dementia. We talk of hobbies, less of interest, repeats the same thing again and again more than 6 times. Trouble learning new things, forgets correct month for the year, trouble handling complicated financial tools, trouble remembering appointments, daily problems with thinking and others. So this informant tool, assessment tool, is very important. And if you find any 2 years, then it is very high sensitivity for diagnosis of dementia. And this is what, and if you mini-cog is, of course, there's a very simple test which can be done by family physicians even in bedside. 3-item recall, like you give them any 3 items, this is banana, sunrise, and chair. And if he forgets, then give 0 to 2 points. So if he forgets 1, you give 1 point. And if he forgets all 3, you give 3 points. And of course, there's a simple clock drawing test. So if you have, again, there is abnormalities, you give them points. So anybody who scores less than 3 is dementia. So this is a simple mini-cog which can be done there. And we, of course, do more formal mini-mental state examination where you test orientation, registration, attention and calculations, recall, language, and of course, visual spatial function by copying design. So this is standard tool we showed. So the total score is 30. Up to 26 is okay. And below 26, you start having problem. And below 24 is dementia. And then finally, you must, in order to manage person, you need to see how functionally he is dependent or independent on. That's why we do a functional instrumentation or holding, how he is able to do. And lower scores in the main mini-mental state probably are associated with lower activity or dealing problems. And finally, behavioral toxicity. Is he on particular drug which is causing problem? Does he have psychiatric issues? And this can be, of course, formally tested by neuropsychiatric inventory, which is done as the formal memory clinics. I think it is always done. So in a person who has dementia, diagnostic imaging structural scan must be done at least one in every patient who is suspected of dementia, because you will find unexpected, such as meningioma, slowly growing, or a subdural hematoma. So at least once imaging is required. And in the positive features, of course, could be atrophy in the medial temporal region suggestive of Alzheimer's disease. And this is the MRI of a person. So various abnormalities on the MRI, you could see medial temporal atrophy with dilatation of the ventricles, cortical atrophy. Same thing shown here in Excel. These are the T1 sequences. in FLAIR images, you can see that maybe they have a bunch of associated of small vessel disease like small infarcts, and they have also SWI images where you could see changes of microangiopathy, cortical atrophy, and probably microhemorrhages, and in or associated in FLAIR sequence, you would see something like a leukoencephalopathy of white matter disease. So scan in Alzheimer's disease may show all this. And the Alzheimer's diagnosis is almost 115 years. There's a person when Alzheimer's this was described by German neuropathologist, and any lecture about Alzheimer's will be without this is not possible. So we should remember Dr. Alois Alzheimer's who described this in 1906, almost 115 years ago. So what are the features of Alzheimer's now? In summary, they are gradual onset over months, clear worsening of cognitive abilities, initial and prominent cognitive deficit by history and physical examination, like amnesia, non-amnestic language disorder, and of course the genetic factor, which will come to. If you people who have MCI, that is mild cognitive impairment, if you follow them up serial MRI, then probably you will demonstrate that the loss of brain volume is at least 2.8% per year, as opposed to normal is 0.2% per year. And this is the hippocampal atrophy shown here again, and probably we'll skip this. So coming to pathology in Alzheimer's, we must know a little bit about it because the newer treatment are based on pathological hallmarks. So there are three consistent neuropathological hallmarks of this: amyloid-rich senile plaques, neurofibrillary tangles, and neuronal degeneration. So you have the protein aggregation of A beta plaques, you have formation of tau tangles, and then ultimately leads to neuronal degeneration. So these are the three hallmarks, and these changes eventually lead to clinical symptoms, but they begin years before the onset of symptoms. And these are the probably biomarkers. So now Alzheimer's disease diagnosis is not only based on clinical and neuropsychology testing, it can be also confirmed by biomarkers. And there are various biomarkers in the CSF, A beta 1/4, so amyloid-related biomarkers, which can be done in CSF, that is reduced A beta proteins in the CSF in people with Alzheimer's disease. You can do a PET scan by various isotopes, which are tracked to demonstrate amyloid in the brain. Then you can demonstrate tau. And the important thing is that CSF, the increase in tau and the formation of tau plaques can be monitored by imaging. And of course, the anatomic imaging, which we already talked about, which consists of serial MRIs showing temporal lobe atrophy, middle temporal atrophy, FDG PET scan, and CSF tau. So this is one of the fluorobeta PET scan, which shows there's a normal person where the amyloid is seen only scanned in white matter. The cortical and white matter differentiation is very clear cut. While a person with Alzheimer's, this differentiation goes away. These isotopes are still not available in India, but they are done routinely. And this is the important point I want to make here is why this is the amyloid deposition can start very early. So a person may be cognitively normal, and still when you stay in with the 11C Pittsburgh compound, you will see presence of amyloid, but person is cognitively normal. So what correlates better with cognition is the deposition of tau, because if you see tau proteins, the tangles are very few here. But as the person goes into MCI, there's much more staining, and as the person goes further, tau goes on. Now, we also need to know this staining because the new treatment are based on this criteria that if you probably choose patients in this area, when the MCI, when they already have amyloid staining, and then you follow them up by using anti-amyloid treatment, and demonstrate that the amyloid deposition reduces, and that is one of the treatment which is approved, but of course it's very controversial as yet, and I'm not going to discuss that in detail. And then these are pathological hallmarks, which are plaques and tangles, and which are intracellular. Plaques are extracellular, and this is probably immunohistological staining, which demonstrate the plaques and which demonstrate tau. And these are hallmark, and these are Lloyd body, which is a hallmark of this. Now the new concept is that all these diseases are proteinopathies, or there is aggregation of abnormal misfolded proteins, either intracellularly or extracellularly, and that is some way responsible for this, or is it a marker of disease? We do not know. But sometimes the more and more theories are that probably they are responsible for neuronal degeneration and neuronal dysfunction. And we need to probably just to remember Parkinson's disease is due to deposition of alpha-synuclein, while Alzheimer's disease is probably A, beta, and tau. And the APOE genotyping, this is genetic factors in dementia, and APOE genotyping is important because if you have APOE4 genotyping, you have very high chance of getting Alzheimer's. The hazard ratio is almost 3 and if you are homozygote for E4, then odds ratio for developing Parkinson's disease, Alzheimer's disease is 8 to 12. But if there is, as opposed to that, if your typing is E2 or E2 and E3, and you're probably a protective, and your risk of developing Alzheimer's goes down to 0.5 to 0.7. The other genes which are responsible is STRAM2, APP, Alzheimer's protein, amyloid precursor protein, P-silaline-1 and P-silaline-2. These are other genetic variants of Alzheimer's disease. Vascular, a few moments, I'll just discuss about vascular dementia, which is usually due to multiple strokes and is diagnosed when you have abrupt deterioration and fluctuating stepwise progression. Usually they have gait disturbance, frequent falls, early urinary symptoms, pseudobulbar bulbar features, personality and mood changes, and subcortical deficit and abnormal executive function. Low-body dementia, just to mention, the only 3 fluctuating, they have hallucinations, visual hallucination is very hallmark, fluctuating MMSE, and presence of Parkinson's disease and high sensitivity to neuroleptic. These are the only 4 points you should remember about low-body dementia. And I think this case I just want to present to just as an example of frontotemporal dementia. Probably time doesn't permit me to go into much, but so this is early onset of dementia between 50 and 60. 40% individuals have a family history, as I mentioned, and they have lack of insight. They're usually a behavioral disorder is the presentation. They have apathy, inertia, loss of sympathy, compulsive behavior, hyperorality, and they have executive functions, but their memory may be preserved. And so anybody who starts at 50 or 45 or 50 and has family history and behavioral problem is a major thing, should think more in terms of frontotemporal dementia. And this is just a small chart which says it. So how do we prevent dementia? I think I'll skip this because we're going to talk more about it in the panel discussion. So because of time permits, I'll probably go into treatment. Treatment part of dementia in Alzheimer's disease, non-pharmacological treatment is very important. So incorporate values, exercise, participate in program-related cognitive stimulation, and probably avoid certain drugs, and take care of that, whether they are able to drive or not. So driving, provide community for medical resources, and regularly reevaluate disease progression in a probably proper way. And what the stable environment, low stress environment, avoid noise and glare, provide security to objects, daytime activities should be organized for them, and also improve their nighttime sleep. And their physical exercises are equally important, and cognitive stimulation programs should be given people with Alzheimer's disease. And these are all important. So apart from the pharmacological treatment, I think one should give more importance to non-pharmacological treatment. The pharmacological, these are the drugs we should avoid, which again, I think I leave it for Dr. Preeti Shabaria in view of lack of time. And so in Alzheimer's timeline of treatment, they are described. Then you have changes in brain chemicals were identified, and then you had acetylcholinesterase inhibitors, drugs which are commonly used even now, started in 1993. This, of course, is no longer used, but these are the 3 drugs which are used. And of course, the glutamate mechanism by mementamine is the drug which is used. This is just the same list: donepezil, galantamine ER, which is not available in India, rivastigmine oral and rivastigmine patch, very popular. Mementamine and mementamine. So only drugs which are available for us is only these 3. So what to expect with these medications? They delay decline in thinking and daily skills by 6 to 12 months. So it's not a curative drug. It will just delay your things, may help behavior and reduce caregiver strain. Important, you should remember side effects: nausea and diarrhea, vivid dreams, muscle cramps, and slower heart rate. So when you prescribe a cholinesterase inhibitor, important thing is people with cardiac disorder, you should probably avoid. Mementamine common side effects: constipation, headache, lightheadedness, temporary delusion. So what I think is short. So what we are achieving with this present drug, just symptomatic therapy. What we want to do is cure, not possible. Arrest progression, not possible. Only thing is by giving drugs, probably we are here. I think the point here, this is the slide. I just wanted to make a point that frontotemporal dementia, cholinesterase inhibitors have no role. Vascular dementia, again, cholinesterase inhibitors have no role. It can be used in other 3 types of dementia. Alternative therapies or supplements, many people will talk about it, hardly of any use. And BPSD behavior, I think this, I can easily skip this. Of course, you should also worry about caregivers, give them holidays. That is one of the problems. They look after the mental health of caregivers, and this is very important part because I think they are the people who suffer more than the person with Alzheimer's disease. Then advanced care planning should now come up very well. This is important, whether there are living wills, medical legal issues, decision making. So I think when the person is diagnosed early, probably this is the stage you should plan out everything for these people. Tube furring should be discouraged. I am of the strong opinion that terminal Alzheimer's patients should never be admitted in ICUs, and they should probably do not resuscitate, should be told right in advance. And these decisions may be taken with the family much in advance. I think the time not permitting, I'll just go to this slide. So I think very common problem is very often people forget. So then the anxiety increases with the am I developing Alzheimer's. So this slide just tries to point out what is normal age-related memory problems. So forgetting where you put your car keys or glasses, etc., is not probably Alzheimer's. It can happen to anybody. Not remembering names of people you haven't seen for several years, not at all very worrisome. Forgetting an item or two in a memorized shopping list, again, not at all important. But these are abnormal are forgetting relationship of close family members, putting things in odd places, forgetting and updating appointments, special event, and still not remembering you even after giving them a cue, and getting lost in familiar place while driving or getting those. So these are the things which probably are worrisome. And if you get this kind of things, probably you should think of it. And I'll go to the just last slide. Yeah, before I go to the last stage. So this is just a case I wanted to present which we encountered about a year ago. This is a 92-year-old gentleman diagnosed to have dementia in 2014. He was seen by neurologist psychiatrist for management of BPSD. He did not tolerate cognitive enhancing drugs, and hence he was being treated with quetiapine and clonazepam for his aggressive behavior and sleep disorder. He was on a number of drugs for his comorbid medical conditions, which include coronary artery disease, hypertension, hypothyroidism, diabetes mellitus. And what we found suddenly that he was pretty independent. And in 2018 June, we found a rapid deterioration in behavior, gait. He developed anorexia, frequent headaches. He had cough and would clear his throat every few minutes, and it had probably inappropriate stereotype behavior. And he had sleep disorder. He was irritable, partially oriented in person in place. He was repetitive, had severe cognitive impairment. He had focal neurological deficits of imbalanced care. So this is a gentleman who had Alzheimer's, which was stable, and he had rapid deterioration or sudden deterioration. So when you see sudden deterioration, always think of causes. So people with dementia or Alzheimer's do not deteriorate suddenly. Their deteriorations are gradual. So please look for correctable causes, infections, medications, pain, other systemic process, neurological process, or post-op. And what happened in this gentleman, when we did that CT scan, it showed a bilateral subdural. So this gentleman had repeated falls and had developed subdural, and that is the cause of his rapid deterioration dementia. So this is just a point I wanted to convey in your practice. So if any Alzheimer's patients deteriorates rapidly, look for a correctable cause, which could be urinary infection or pneumonia or anything else, which I think we'll discuss as we go further. So by concluding slides, you have normal aging, decreased processing speed, reaction time, ability to manage new complex information may go down after normal. That's normal. Mild cognitive impaired in more than one area of functioning, normally high risk of progressing. And then you have dementia where you have more than impairment of more than 2 areas of cognitive functioning. More diagnosis clinical based on a combination of history, examinations, studies to rule out other causes. And finally, memory and thinking change with aging. This does not predict Alzheimer's disease. The tasks take longer, but can still be done. Many risk factors of AD can be modified. The glass is not half empty. Simple steps like exercise, diet, brain games, focusing on wellness can prevent dementia. This is not magic. Many of the exact mechanisms are known. Healthy lifestyle choices may already have reduced the incidence of dementia. And this is, the famous people who had Alzheimer's disease, Charles Hanson and President Reagan. And thank you for your attention. Sorry, I went for the time. Thank you.
Thank you very much, sir. It was really an excellent presentation. We have a comment in our question answer box that this lecture should be repeated. It was such a nice presentation. Okay, so there are many questions, but I have one question. Can you just throw light on post-COVID dementia?
I think as my colleague is going to address this, so should we leave it there and
Yes,
see and save time? And I think other thing is we thought that question answer again we can put it in the panel discussion also.
Okay, we'll do
so
that.
I think I'll just briefly mention this fogging and all that has been described post-COVID, mental fogging. But I don't know whether real dementia occurs. But there is, of course, the people with Alzheimer's and all that rapid deterioration is well known during COVID and post-COVID. So, of course, Dr. Manisha Burya might dilate on that.
Thank you very much, sir. And it was really a fantastic presentation. We'll have questions in the panel during panel discussion. Some of the important questions we will take. So I request the delegates, to put the questions during the lecture only, because what happens most of the time, what I see is when we finish the lecture and then when we go on to the second lecturer, a speaker, then lecture as the questions start coming. So it is always better you put your question during the lecture only. So friends, the next speaker is Dr. Joy Desai, and I just put his slide. Yeah, just a minute. So slide is not moving.
It's quite okay. I think we could proceed.
Yeah.
To
just a minute.
Yeah, Dr. Anil, yeah.
Dr. Joy Desai is a consultant neurologist in the Department of Neurosciences at Sir H.N. Reliance Foundation Hospital and Research Center. He completed his MBBS and MD in internal medicine from BJ Medical College, Ahmedabad, Gujarat. During his period, he was awarded 3 gold medals for distinction in anatomy in 1985, for distinction in general medicine in 1987, and for distinction in internal medicine in 1991. He then completed his DNB in neurology at the Jaslok Hospital and Research Center. He then did fellowship in clinical neurology from Royal London Hospital, London, UK. He also did fellowship in clinical epileptology at the Cleveland Clinic Foundation, Cleveland, Ohio, US. He is an honorable member of the Indian Academy of Neurology, the Neurological Society of India, the Indian Epilepsy Society, and the Indian Epilepsy Association, the British Epilepsy Association, the American Academy of Neurology, and the Indian Medical Association. He has presented several award-winning papers and presentations over the years He has several research and presentations both nationally and internationally to his credit. I request Dr. Joy Desai to proceed with his presentation.
Thank you, Dr. Abhad. Thank you, IMA, for asking me to participate in today's meeting. And I'd like to thank Dr. Arun Shah and our department at Reliance for making me a part of this meeting today. And this is a subject close to my heart. And in the next 30 minutes, I shall discuss with you all the relationship of lifestyle and cognition. And if one looks at cognition as a viable, tangible, brain-derived process, then this cognition can be thought of as a reflection of our actual lifestyle throughout adulthood and middle life, progressing into geriatrics. And why do I feel that? Well, I'll hope that in the next 30 minutes, I'll convince you that there are numerous facets of lifestyle that could have a bearing on how our brain behaves as we march with time from youth to geriatrics. The concept of cognition to the common man is that it's a mental action or a process that requires knowledge, understanding through experience and the senses. And essentially, you heard Dr. Arun Shah introduce to you the concept of what happens when cognition fails in a person with dementia. And what do we mean by lifestyle? Lifestyle, if you look at the definition of lifestyle, then lifestyle is thought of as the interest, opinion, behavior, and behavioral orientation of an individual, group, or culture, which implies that it depends on how we live our life on a daily basis as a result of our core beliefs as an individual, as a group, or a culture, and that's going to be a determinant, as I implied, on how our cognition is going to behave. So what I provocatively put to you today is that if one looks at dementia, and you heard Dr. Arun Shah tell you that you need at least 2 or more domains of cognitive functioning to be impaired and the fact that it should affect your quality of life and it should be a drop from your pre-existing abilities for it to qualify for a consideration of the presence of dementia in a given individual. These are the domains that are listed on the left-hand side. These cognitive domains are memory, personality, language, visuospatial ability, and praxis. Praxis is the innate ability to do a complex learned task, which is sequential, without having to focus attention on its individual components. That means the ability to handle the remote of a television or the ability to use a device in the kitchen is based on sequential learning. And if that gets disrupted, then we call that apraxia. And finally, you have the last domain of executive functioning, the ability to understand cause and effect, the ability to understand differences in categories, and the ability to make decisions that are productive based on anticipated outcome. And these require frontal lobe functioning. And the question that we are discussing today is that do these domains depend on how we live our life? So is it related to exercise or sedentariness? Is it related to how we consume our diet? What is the relationship of consumption of fruits and vegetables versus, say, meat and processed foods? How is it related to social connectivity versus isolation? How is it connected to sleep hygiene versus indiscipline in sleeping habits? And how is it connected to stress versus the ability to stay calm in stressful situations, what we call equanimity? So there are numerous studies, and I'll just introduce you to 2 of them as an example of these are cross-sectional studies that assess cognitive reserve and lifestyle. And this is once a study. This is a study from the Wales group where they looked at 2,315 cognitively healthy individuals aged 60 and over, and they followed them up, assessed them, did their cognitive testing, and looked at a multiple regression analysis model on their lifestyles. And when they controlled for age and gender, cognitive and social ability, physical activity, healthy diet and light to moderate alcohol consumption were clearly associated with a good cognitive functioning and accounted for a decrease in the risk of dementia in time to come. And the Welsh study is associated with other studies, and this led to an assessment of the Mediterranean diet and the Mediterranean lifestyle. By Mediterranean diet, we mean a diet that is rich in fruits, vegetables, and seafood, which are thought to have a high content of polyunsaturated fatty acids, PUFA as we know them. And there is also a Mediterranean concept that you consume your meals before 7 o'clock in the evening, by 7 o'clock in the evening. And if you do consume alcohol, you have it earlier in the evening between 5 and 7, not late in the night. And this Mediterranean lifestyle has been studied by the Greeks. This is a Greek study of 1726 participants, and a very comprehensive neurological and neuropsychological assessment was conducted with all cognitive domains: memory, executive function, visuospatial, language, all the domains that I talked about. And 2 lifestyle indices were constructed. And what came through is that a Mediterranean diet, sleep quality, and physical activity was associated with a 9.8% versus 7.1, 6.8, 7.2, and 8.5 increased odds for better memory, executive functioning, visuospatial perception, language, and global function. So what it means, if you want to decipher this seemingly complex study, what it meant is that if you analyze distinctively the effect of lifestyle in well-conducted studies, clearly there is a relationship between lifestyle and the ability of the brain to cope with the passage of time and not be vulnerable to the ravages of dementia. And finally, this is a Chinese study done fairly recently from China, and they have taken people aged above 50, which includes people like me. And clearly, this Chinese study also found a relationship between physical activity and a higher vegetable and fruit consumption as being protective for the risk of dementia, whereas obesity and sedentariness was detrimental in its relationship to the prospect of cognitive decline in older age. So what is the basis of all this? I mean, it's okay to say that have a better diet and exercise and sleep better. So why are we saying this thing? What is the actual basis for it? If one really wants to understand memory, then memory is the hippocampus is the actual hub of memory receiving and processing that temporarily stores all our memories through experiences that we have in our daytime. Neurons, astrocytes, and networks in the brain, they have a complex mechanism of talking to each other through ionic movements across the neuronal membranes. We call that cations, and this chatter itself forms a network. And if this cation-driven chatter is long enough and loud enough in the brain for our experiences, then permanent patterns are developed, and these patterns require the neuronal cells to have protein kinases. Now, in sleep, there is a data transfer that occurs from the hippocampus to the neocortex. That means the hippocampus can be understood as a little pen drive for temporary storage of our memories. And the hard drive of the brain are the cortices of the brain. And sleep is the actual cable. And sleep rhythms are the connecting cable that are transferring memories when we sleep at night. And all of these processes are influenced by lifestyle. And a lot of this work came from Matthew Walker's group in Helen Willis Institute of Medicine. What they showed is that during non-REM sleep, electrical changes occur in the brain in a hierarchical manner. So there are 3 electrical rhythms: hippocampal ripples. These are followed by slow wave oscillations in the brain that couple with sleep spindles. And in this phase of non-REM sleep, memories get transferred from the hippocampus to the frontal and parietal and occipital lobes for consolidation. And it is in sleep that relevant memories get consolidated while irrelevant ones are getting wiped out. That means our sleeping process is actually shuffling our memories in the phase of sleep. And it stands to reason, therefore, that if sleep health is impaired, this process of acquisition of memories is also going to be impaired. And therefore, at a general practitioner level too, I think it's important to recognize that we have three electrical rhythms in our sleeping brain: the ripples, slow wave oscillations, and spindles. And these rhythms, if they are intact in a human brain, then their intactness is responsible for this very seemingly complex process of data transfer from temporary storage in the hippocampus to the frontal and parietal lobes. And the same group from Helen Willis in Berkeley, Matthew Walker and Bryce Mander and Adam Krause, they have done numerous studies in the last 7 to 8 years. And in one of the cardinal studies, which got published in a very high-end journal called Neuron, they demonstrated that an older brain becomes uncoupled in sleep because of a poor efficiency of these three rhythms. And the reason for this uncoupling with age is a age-related atrophy in the mesial prefrontal cortex. So let me show you in this diagram the mesial prefrontal cortex. So these are examinations done in young adults, shown in the red chart, bar, and the blue bar shows older adults. So what it means is that as we grow older, the prefrontal cortex of the brain is becoming gradually smaller, and the density of gray matter in the prefrontal cortex. We now know that this prefrontal cortex is the generator of these slow wave rhythms. It's also the generator of these spindles. So it stands to clear understanding that if these cortices atrophy, then and they become smaller, the efficiency of sleep-related memory is going to get poorer. So what can we do about it? Well, we now know that there are numerous lifestyle measures that have an effect on the volume of the prefrontal cortex. So this diagram shows you the components of the prefrontal cortex. So if you have recurrent head injury, if you are aging, if you drink too much alcohol and binge on alcohol, and if you are seriously depressed, then these are factors that are associated with a gradual shrinkage in the prefrontal cortex. We have lots and lots of data that has shown that if you exercise, if you practice mindfulness, which is meditation, or if you do yoga, or if you are socially connected and you are enthusiastic and passionate about the activities that you do. And with this whole thing, enthusiasm and passion is linked to the salience of the anterior cingulate gyrus, shown here in this diagram in yellow. And this is a very big area of cognitive research now. And to this, one can add sleep health. If these are in place, then the prefrontal cortex stays good, and therefore it translates into a greater likelihood that the age-related decline in memory processing may actually not happen in people who are mindful of these facets of lifestyle. And in order to make our understanding of our brains and sleep a little more coherent and illuminative, we now, in 2013, somewhere in August was the Michael Nedegard's publication, that we discovered that the brain has an excretory system called the glymphatic system. The word glymphatic is derived from glial and lymphatic. Just like you have the lymphatic system in the body that is responsible for waste clearance from the vasculature of the body, in the brain, there is an exclusive sleep-associated excretory system. And this system is called the glymphatic system. And what does it actually do? We are going to discuss that in the next few slides. So this is a sleep-activated brain cleaning service. So you can imagine that our brains have a service, just like you send your car for servicing every month so that it runs well for the interim period between servicing. Our brain is actually serviced every night when we sleep through a process of cleaning via this glymphatic system. So this is the brain's cleaner. That's the best way to understand it. So what is this glymphatic? So it is a unidirectional flow of cerebrospinal fluid, which is mediated only in sleep, and it abates as soon as we wake up. And the reason it abates is because of adrenergic tone on awakening. When we sleep supine and lateral, then the glymphatic function is optimal, and sleeping prone does seem to decrease the efficiency of this glymphatic clearance by about 40%. We have a large body of scientific evidence that shows that voluntary exercise and low dose alcohol actually enhances this glymphatic efficiency of our nighttime brain clearance. What about systemic disorders? Head injury, diabetes, strokes, especially lacunar, and obstructive sleep apnea impairs glymphatic efficiency on a daily basis, especially if it is left untreated. And lastly, we have a very large body of evidence now in the last 5 years, which shows that glymphatic function, what does it remove from the brain? It removes beta amyloid and tau in normal asymptomatic individuals. Therefore, obviously, it is going to be important how the glymphatics behave in a person who has dementia, because you heard Dr. Arun Shah so elegantly explain to you the relevance of beta amyloid and tau deposition in the human brain in producing the tragic consequences of Alzheimer's disease. And therefore, in patients with Alzheimer, sleep efficiency is going to be an important thing. This diagram is a very cogent explanation of what simply happens in the brain. So you have the artery shown on the left in red. You have the vein in the brain shown in blue on the right. In between, in the beige color, is the interstitium of the brain. And the big cell that you see is the human astrocyte. And the astrocyte has a molecule on its foot process that is shown here in green. That molecule is called aquaporin 4. If the astrocyte has all the aquaporin 4 polarized to the foot process, then in conjunction with good breathing at night and good sleep efficiency, CSF moves from artery to veins, and it takes away the interstitial solutes, which are amyloid and tau. Okay, so remember this astrocyte. It is actually not the neuron that is the star of sleep and the glymphatic system. It is the astrocyte which is the star of the glymphatic system. This glymphatic clearance, amyloid and tau removal, is important because it moves from artery to vein. It requires the polarization of aquaporin 4 on the foot process of the astrocyte. That means the aquaporin 4 should not be on the cell body. It has to remain on the foot process. Mediterranean diet, fish oils, polyunsaturated fatty acids, exercise, including exercises like Tai Chi, low dose alcohol, and meditation. All of them have now been shown to improve the polarization of aquaporin 4. I will not take you through all the studies, but those who are interested can communicate with me and I can share with them the basic science studies. This enhances amyloid clearance because it improves the function of the astrocyte when you are asleep, and especially when sleep hygiene is optimal. So sleep disorders like insomnia, sleep apnea, fragmentation of sleep, shorter sleep over a lifetime. Remember the photograph of Ronald Reagan? Ronald Reagan is known to have said that I need only 4 hours of sleep. And sure enough, he and Margaret Thatcher, both who have been known to say that, actually had Alzheimer in the end and they died. So all of these processes are important for brain health. And this diagram is an explanation of what I told you. What you have at the top is the healthy condition. What you have at the bottom is the Alzheimer's disease. And you can see that if the aquaporin 4, which is shown here in dark blue, if it is not polarized, then CSF flow does not occur and it results in greater amyloid in the interstitium of the brain, ultimately resulting in a greater risk for developing Alzheimer's disease. we now have some fascinating biological data. This is a study from China, which shows that intermittent fasting protects against Alzheimer's disease through restoration of the polarization of aquaporin 4. So they have shown that if you do intermittent fasting from, say, 8 p.m. at night to roughly 10 or 11 the next morning, on a regular basis, the polarization of aquaporin 4 is improved, and therefore the clearance of the glymphatic functioning is enhanced in such people. I think this is one of the most fascinating things I have come across. There is a study, or maybe at least two studies, which show that low dose alcohol, but not high dose alcohol, which means very low dose alcohol consumption, can improve the glymphatic efficiency, shown here in the middle. Whereas if one drinks every day and large amounts of alcohol, then the astrocytes become dysfunctional, and it actually is bad for glymphatic function. So my own perception is that if you don't drink, you're quite okay. And if you do drink, don't drink often, and drink very, very modestly if you like your alcohol. We have lots and lots of data to show that voluntary exercise improves glymphatic clearance and amyloid beta, and it decreases the activation of astrocytes and microglia in mice and in humans. And there are huge bodies of evidence to show that. So the current notion is that the sleeping brain can be harnessed to improve the power of the glymphatic system through our lifestyle choices. If our lifestyle choices modify the astrocytes, we can contain Alzheimer's disease. And lifestyle, neural degeneration, and microglia. Microglia is the third type of glial cell in the brain, and it is these activated microglia that produce brain injury in Alzheimer after the accumulation of amyloid. So even microglial activation improves with these lifestyle measures. We now know that obstructive sleep apnea is associated with early and modifiable biomarker change in the CSF. It's been shown to be associated with a higher amyloid burden on the floor beta PET studies from Australia. It's done in Melbourne. You have OSA patients, you do a floor beta PET, they have a greater amount of amyloid in their brains. And even the association of sleep duration in middle and old age is associated with incidence of dementia. If you are sleeping 4.5 to 5 hours only in your middle life, consequently, over a period of a decade, it makes your risk of dementia increase by 30%. So here's the gist of what we discussed. This is the brain on the left with insufficient clearance, waste accumulation. Those yellow tangles are the amyloid. So sleep disturbance, stress, hypertension, high amounts of alcohol, and poor diet choices can do that. And on the right, you have a nice CSF circulation in sleep, a nice glymphatic clearance in sleep. And here, there is effective brain clearance. So sleep, vascular health, exercise, if you drink low levels of alcohol, and wise dietary choices, they all result in a cleaner brain when we sleep at night. And there is now data to also show that our dietary choices, especially the Mediterranean kind of diet, it has a strong effect on the complex process of what is called microglial activation. It is this activated microglia that produce brain injury and enhance amyloid burden and tau accumulation in the brain when you have risk factors like what Dr. Arun Shah told you, a gene like ApoE or TREM2 or R47H and so on. So clearly, there is some very exciting science which proves what our sages told us many years ago, that early to bed and early to rise and intermittent fasting, wise choices in food and exercise have a bearing on brain health. So this is a composite kind of diagram. I know it looks very complex, but what it means in essence is that this deregulation of the glymphatic system is responsible for beta amyloid accumulation in the brain. This can be worsened by stress because of increased cortisol. It can be worsened because of diabetes. It can be worsened because of dietary wrong choices, organic foods, processed foods, animal proteins, and refined sugar, all of them have detrimental effects on it. Sleep disorders like sleep apnea and OSA and sleep fragmentation, through their complex physiological effects, can change oxidative stress, endothelial dysfunction, brain metabolism, and insulin resistance. All of them can produce a poorer glymphatic function, making the brain more vulnerable to Alzheimer's disease. So, what are the lifestyle influences that modulate memory? We now know that sleep optimizes memory consolidation for appropriate retrieval. We also know that poor sleep hygiene in any form impacts this memory functioning. And I think this is a message that I would strongly like to promote to this audience today. It's important for you to talk to your patients and change how they are behaving in the community. Alcohol consumption in excess and definitely prior to sleep. So if you're consuming alcohol 2 hours before you sleep, then slow wave synchrony, fragmentation of sleep does occur. And this is going to affect memory. Chronic alcohol consumption distinctively is associated to prefrontal atrophy and is going to make glymphatic function worse. Exercise improves blood flow to the hippocampus. It improves neurogenesis in the dentate gyrus, improves cognition, and all this is mediated by brain-derived neurotrophic factor. And this also modulates glymphatic function. Stress and anxiety worsens memory due to suppression of all of these processes by increasing cortisol. So remember, we don't need too much cortisol in our system. Cortisol is needed for fight or flight. So if you're not fighting, then your physiologies are likely to remain more robust. So science, I think, is unraveling the complex mechanisms that establish and maintain human memory. We now know that it is moderated by many lifestyle factors that cannot be taken lightly. Diet, exercise, sleep, meditation, enthusiasm, passion, hobbies, and innovative activities. All of them are neuroregenerative. Degenerative disease can produce impairment in memory. It has a very distinct biological basis. And you heard a very elegant first 30-minute talk on the different biological processes. There are some treatments that can restore and rehabilitate function, but unfortunately cannot restore biology. The only thing that we can actually do today is to try and prevent Alzheimer, because lifestyle is a major determinant of the robustness of memory. So in my view, what are the 10 cognition commandments that we should remember? Be active. Be active as often as you can. Exercise. Avoid sedentariness. Make sure that every few minutes you get up and walk, even when you are in the clinic. Indulge in fruits and vegetables. The older you are, greater should be our indulgence in fruit and vegetables. Pass the grain and meats. That means eat less grain, especially processed food, and definitely avoid red meats if possible. Connect socially, not on a device. It's important to generate social enthusiasm in human interactivity, and that is the cingulate gyrus enhancing social function. Develop hobbies. Take up something with a passion. That improves how your cingulate gyrus develops. Avoid stressful activities and pursuits, and do not get into behavior that is likely to perpetuate stress. If you do imbibe alcohol, moderate your consumption. Imbibe occasionally and stop when you have had one drink or two. You must treasure sleep hygiene, and I think it is very important to get sleep disorders treated. Thank you very much for listening, and I believe I have stopped on the 29th minute. Thank you for your attention. I shall stop sharing my slides now.
Thank you very much, Dr. Joy Desai. I wanted to show the delegates because the picture which you have shown, that I think it is drawn, painted by you only.
Yes.
The last slide.
Yes, that's right.
So we have to indulge into such activities also.
There were the 10 commandments.
Yeah, yeah.
Genuine 10 commandments to have a healthy life.
You should indulge into hobbies and whatever you have. Things. So thanks a lot. It was really a wonderful lecture, and you have clearly explained how a lifestyle modification can change your memory pattern and brain functioning. We will have question. So you are there in the panel.
Yeah, I'll be here. Don't worry. I'm not running away. I'll walk around a bit in the room and come back and
As
sit here.
Dr. Arun Shah said, we'll have questions.
I'm here. I'm here. Don't worry.
Yeah. So
I have to listen to my other colleagues too. So
yes. Thanks a lot, sir, for a nice presentation. And we now move on to the next speaker, and Dr. Manish Chabria is going to speak on COVID-19 and dementia. And I request Dr. Kashyap Dakshini, who is a member of IMA CGP Mumbai staff faculty, to introduce Dr. Manish Chabria.
Good morning, friends. Dr. Manish Chabria is a consultant neurophysician at Sir H.N. Reliance Foundation Hospital and Research Center. He has completed his DNB in general medicine and then DNB in neurology from PD Hinduja National Hospital and Medical Research Center, Mumbai. He has also worked in the PICU at BJ Wadia Hospital for Children, Mumbai, and was a clinical associate in the Center for Brain and Nervous System at Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute, Mumbai. He is an instructor for Advanced Cardiac Life Support, ACLS, and Basic Life Support, accredited by the American Heart Association. He has presented several award-winning papers and presentations over the years in neurology conferences. He has many publications in national and international journals, books, and newspapers. He has also contributed in the book Practical Methods in Clinical Medicine, published in 2010. He has special interest in stroke medicine, neuro-oncology, movement disorders, neurodegenerative disorders, multiple sclerosis, epilepsy, and neurophysiology. Today, he will be talking on COVID-19 pandemic meets dementia pandemic, a double blow. Welcome, Dr. Chabria.
Thank you, Team IMA. Am I audible?
Yes, sir.
Yes.
Thank you, Team IMA. Thank you, Dr. Arun Shah, for giving me this opportunity to give a presentation. I'll be sharing my slides. Are my slides visible?
Yes, sir. Yes.
So, as we all are in the midst of the COVID pandemic, and all of us have been affected by this, and as we know, dementia is, there are lots of patients of dementia in India and globally. So these two things have met, and what has each impacted on each other, I would like to, I will try to mention and try to find out if we can do better for these patients of dementia who are already in the midst of the COVID pandemic with all of us. So as we all know, dementia is an existing pandemic. It's basically a syndrome of deterioration in cognitive function, as we have already seen, beyond what is expected of normal biological aging. But it is not an inevitable consequence of aging. It mainly affects elderly, but we are seeing that in the middle-aged too. Currently, there are more than 55 million globally patients of proven dementia of various causes, and around 10 million have been added every year. And what is striking is 60 to 70% are in the low and middle income countries. And what is projected is by 2030, there will be 78 million, and by 2050, it will extrapolate to 139 million. So the patients of dementia are growing exponentially. Alzheimer's disease, as we all know, is the most common. 60 to 70% of cases of dementia, Alzheimer's is the most common form of dementia. And dementia overall is the 7th leading cause of death, major cause of disability, dependency, and globally it has affected a large number of population. it causes a lot of impact physically, psychologically, social, and economic. And if this was not enough, the arrival of the coronavirus. So coronavirus has presented as a pandemic of unprecedented threat to global public and psychosocial health. As we all know, it was first detected in Wuhan in 2019, and the WHO declared it as a pandemic on the 11th of March in 2020. The first case of COVID-19 in India was detected on 30th January of last year. And as we all are aware, India is among the worst hit countries by COVID-19. And we all know that it shares a significant dementia load. And India is aging fast, if we may believe. 20% of the population would be more than 65 years by the age of 2050. And at present, there are 5.3 million patients of dementia presently in our country. And persons living with dementia face a dual risk due to both age and cognitive decline, which are accentuated by the pandemic, as I may present in the next few slides. What are the CNS complications? As we are talking about dementia, I thought we should first see how the CNS gets affected by the COVID-19. So these are the enveloped RNA viruses, and the host cell entrance is through the ACE2 receptor, which is the angiotensin converting enzyme receptor. This is required for cell entry for the COVID-19. And ACE2 is widely distributed in the body. It is mainly the cardiorenal protective factor. As we all know, blood pressure control and other things are modified by the ACE2. It's widely distributed. SARS-2 causes neurological manifestations which are varied, right from the brain up till the nerves: anosmia, delirium, acute cerebrovascular disease, paralysis, meningoencephalitis. The entire spectrum we are seeing and will we keep seeing with COVID-19. And as per one study, 36% of the COVID-19 patients have various neurological manifestations of some kind or the other. And some experts do believe, there are some studies coming, that SARS-2 may be directly causing neurodegeneration, as we may see in the next few slides. There is no clear evidence, though, despite few studies being there, that there is any relation between dementias and COVID-19. But there is emerging evidence which says homozygosity of the ApoE4 increases the risk of severe COVID infection. And as we all know, ApoE4 is related to Alzheimer's disease and cardiovascular disease, but as well as various number of viral infections, as studies have shown. So SARS-2 patients having this ApoE homozygosity are known to have severe COVID infection. So the ApoE gene is not a single gene locus. It involves the nearby area where the severe viral infections also are known in them. And in the patients of dementia, increasing risk of COVID-19 infection, hospitalizations, and mortality are independent risk factors, besides the other demographics of these patients. So definitely there is some link which is found between the genetic propensity of the ApoE4 in some studies and having a link with dementia and severe COVID infection. What are the three mechanisms by which COVID affects the brain? The first mechanism is direct pathway, direct cytotoxicity through the bloodstream, that is hematogenous spread, damage to the blood-brain barrier because of inflammation. And we should all note that meninges have very high level of ACE2, which is required for entry of SARS-2 into the cell and causing the pathology. And as I said, ACE2 is present in the numerous organs. Besides the respiratory and olfactory epithelium, it's present in the piriform cortex, hypothalamus, thalamus, parahypocampal gyrus, basal ganglia, and amygdala. And that is the explanation how SARS-2 can affect these areas where memory and various other cognitive functions are present. What is the second mechanism? It is the indirect pathway, or the effect of the immune and the inflammatory reaction by the SARS-2, causing activation of cytokines and hypercoagulation pathway, which affects the brain and its structures. And we should all know that elderly have an increased baseline inflammation already due to aging. And on the top of that, if a person gets COVID, the cytokine storm and the excess inflammation can affect the brain and its functioning. What is the third mechanism? Hypoxic brain damage, especially in severe cases. And these patients present acutely as confusion, disorientation, delirium, and loss of consciousness. So as has been previously discussed, that we need to differentiate between an acute cognitive decline and a patient who already has dementia. So patient with severe COVID can present with acute deterioration in their cognitive function, and we should look into that factor too. So the studies have said abnormal misfolding and aggregation of proteins in severe COVID it could be the reason for long-term brain degeneration. So some studies have quoted that. So that may be the reason for cytotoxicity or the brain cells getting affected. Helms and colleagues have said 1/3 of COVID-19 patients discharged from ICU have a dysexecutive syndrome. That means they have difficulty in planning, executive functions, personality changes when they come out of the ICU and they are in the recovery phase. In the recovered patients, studies have shown poor attention, poor memory, and slow processing speed. Hence, the studies have said that these patients should be followed up very closely, and an assessment periodically 6 to 8 monthly should be done after discharge to help them regain that and to plan the rehabilitation. So early brain rehabilitation in patients with cognitive decline post-COVID reduces risk for further age-related cognitive decline. So that is very, very important. So these patients should be followed up very closely. Augier et al. Have shown that follow-up screening, in addition to clinical cognitive evaluation and imaging, MRI, PET, or a BERA, as indicated on a case-to-case basis, may help us to detect future cognitive decline and prevent accelerated aging and dementia in these COVID patients. Of course, these are early studies. As time goes and more studies come, we will get a more concretive guideline on this. So what has impact of COVID-19 on various dementias? So the first, I would like to discuss few points about each. Mild cognitive impairment. So most individuals of mild cognitive impairment can do their basic activities of daily living independently. But patients in this pandemic, patients affected, the families affected. So these patients have impaired adaptation and responses to changes in the society, like social isolation, social distancing, remaining alone in the house. So this pandemic can affect these patients in this way. This pandemic has caused lack of exercise, social connection, and this may accelerate their cognitive and psychological decline. Overall stress can have detrimental effects on their cognition. And Rogers' systemic review in one of these studies have found out that acute and post-illness neuropsychiatric features of COVID-19, like depression, anxiety, fatigue, and stress is very commonly seen in these MCI patients. Coming to Alzheimer's disease. So as we have seen, as sir has already discussed, Alzheimer's disease causes long-term memory loss, gradual deterioration of language. As the disease progresses, there is reduced awareness of time and place, inhibition of their abilities of basic activity of daily living without help. So these patients again will have difficulty in understanding and complying with the new policies of the pandemic, that you don't have to go out, you don't have to meet people, you have to wear a mask, you have to wash your hands. So they have difficulty in understanding because of their already compromised cognitive function. They have difficulty in understanding and adjusting to the pandemic situation. The confinement which has been there in these lockdowns will affect their neuropsychiatric symptoms, and these can be assessed very clearly. And I'm sure Dr. Ashutosh, and in the panel discussion, he would put more light on this. There is higher tendency for Alzheimer's patients to develop confusion and disorientation because of this isolation in the lockdowns in the pandemic. Coming to vascular dementia, there is cognitive decline depending on the brain region which is affected. There is memory loss similar to Alzheimer's, and depending on which part of the brain has got affected because of vascular damage, like if the frontal lobe gets involved, there can be additional symptoms of frontotemporal dementia along with the Alzheimer's, along with the memory dysfunction. There is memory, behavioral, and neuropsychiatric symptoms which make these vascular dementia patients more susceptible to COVID-19. They don't remember, the behavior may be different. The motor, sensory, and neurological deficits and cognitive problems will get aggravated because they need a good rehabilitation. Patients of vascular disease will have hemiparesis, they will have speech difficulty along with cognitive. So if the rehab programs, as we have seen, have got disturbed in this pandemic because of patients not coming to the rehab center or not getting medical help on time. So these patients, the rehab is very important, and that has got disturbed in this pandemic. Coming to dementia with Lewy bodies, as we all know, it's a synucleinopathy because of synuclein in the brain cells, and it has symptoms of memory impairment and Parkinsonism. They have delirium-like presentations, like fluctuating symptoms, visual hallucinations. So a patient coming with these symptoms, other cause of delirium needs to be differentiated. They have hypersensitivity to antipsychotics. They have agitation. They have behavioral problems. And if we give antipsychotics or if some form of these medications are given, they can further increase the cognitive decline, cause drowsiness, agitation, delirium, and worsening of their Parkinsonism. So giving antipsychotics to these patients, we have to be very, very careful in a patient suspected of having dementia with Lewy bodies or patient having a proven dementia with Lewy body, because in this, any infection like COVID-19 or any viral infection, if patient gets delirium and we give antipsychotics, it may worsen their cognitive function. There is increased risk of falling, thereby restricting their daily activities. As I said, they have symptoms of Parkinsonism, gait instability. So if the patient doesn't have any attendant at home, if the patient is living alone in this pandemic, there are no caregivers, there is increased risk of falling. They can get head injury, they can get bony injuries. So dementia with Lewy body patients, in this way, the COVID-19 pandemic has affected them. Coming to frontotemporal dementia, it is seen in a younger age group, 45 to 65. There is behavioral variant, there is the aphasia variant, and we see early symptoms of behavioral language problems in them, difficulty in understanding. So they will, again, these patients will have difficulty in understanding the quarantine rules. They have difficulty in staying at home. They don't get help. They don't accept the unfamiliar social guidelines because of the personality, because of the difficulty in understanding the things. They are younger, the frontotemporal dementia patients. So they can get violent behavior, impulsivity, disinhibition, dysexecutive impairment because of the restrictions. The daily activities can get hampered. And because of their behavior, because of not understanding the masking, washing hands, using the sanitizer, they will become more susceptible to infection and transmitting the COVID infection. So the different spectrum of types of dementia affect the patients in a different way based on what symptoms they are getting. So what are the challenges that the dementia patients face overall during the COVID-19? The normal routines are disrupted. There is lack of cognitive stimulation, no socialization, feeling lonely, anxious, abandoned. They risk depression. Early stages, the patient may cope well, some of the patients, but others will develop deterioration in their overall cognitive function, sleep disturbances, changes in behavior, self-neglect, premature hospitalization because of delirium, because of exposure to infection. They can't tolerate cocooning, that is staying alone at home or in a residential care. They can't understand distancing, the purpose of protective clothing, the purpose of social distancing. And I would like to state, in one of the studies which I read, the WHO has cautioned on the use of the term social distancing, because when you say social distancing, it's an emotional disconnect from friends, from near and dear ones. Hence, they suggest to rechange the word from social distancing to physical distancing, which is required to prevent transmission of COVID infection rather than social distancing, because that will prevent the emotional disconnect which these patients need. They need emotional support. What other problems they are facing? Families and relatives visits have stopped or reduced during the lockdowns. Many healthcare and social professions isolate themselves because they themselves have got infected. A lot of our healthcare colleagues got infected. In that way, there is staff shortages, further disruption, everything is happening virtual, less patients, the face-to-face visits have reduced. If once you start working, once they were on the site as frontline, as we all are in frontline, they themselves become at the risk of infection. So social vulnerability, frailty, and it's a very typical triad of the elderly patients which has affected their cognition. And social isolation, as we have seen, as Sir mentioned, causes increased morbidity and mortality and cognitive decline. It increases the risk of dementia. It increases memory decline. There is post-traumatic stress disorder because of isolation and various myriad of psychiatric problems. What is the challenges faced by the informal carer during the COVID pandemic? Relatives, partners, close friends have got affected. As in the Indian setting, I would be discussing the subsequent slide. Family is the very important informal caregiver in India. There is disruption of normal routines, loss of support and services. There is additional care which has to be taken at home. Concerns about their ability to cope because of the stress. They themselves are at the risk of infection, stress, burnout, abuse. And when they can't take care, they need help. They need help of a nurse. They need help of an attendant. And they have to rely on people who are entering their home to look after the elderly. And they may not realize that they may be harboring the COVID infection, asymptomatic COVID infection. So they will put themselves and their elderly at risk because of that. There may be difficulty in understanding their language because a strange new person may come and look after. There is lack of trust, cultural changes. If the carer is an older one, they have their own health concerns. Maybe the family member or who is coming to look after the patient. So they have to look after their health. What is the challenges that we are facing as healthcare workers? Fears of our own, family safety, increasing workloads, lockdowns and distancing, restriction, which is affecting the morale, loneliness, and depression. So how do we look after the patients, elderly patients of dementia who have contracted COVID or their risk of contracting COVID? Of course, it's a busy slide. I would run through it. Acute care, we have to look for delirium, that is acute worsening in cognitive functions, precipitating factors for delirium, reduce the impact of isolation, early mobilization. Transitional care is well prepared to meet the mental health needs. We need to give a supportive environment. We need collaborative effort from the family support and the carer who is coming to look after the patients. We have to be vigilant for early COVID symptoms because elderly are more susceptible to COVID. Long-term care is a multidisciplinary, holistic approach, psychosocial approach, screening for anxiety, depression. Palliative care, which is again a very, very important part of looking after the elderly with COVID and at risk of COVID, and various ethical issues. If the patients get hospitalized, whether patient needs, whether an elderly patient who has severe COVID, who's on a ventilator, how long the treatment should be pulled on, what are the DNR status, what is the comfort care, all those ethical issues have to be thought of, and they have got accentuated since this pandemic has arrived. Activities that may help in a dementia patient besides the care which I discussed, besides the medication, what else? So every interaction can create a moment of connection with the patients, like greeting by name, making an eye contact and smile. Of course, this is done in India by the family as an informal carer. Reassuring words, complimenting, evoking a happy memory, family photographs, a flower arrangement, a very happy environment, open-ended question to start a conversation, brain aerobics. Of course, whatever I'm discussing, Dr. Shraddha in her talk, I think will highlight more on this. Information, what is given to the elderly patients with dementia have to be done very slowly with frequent pauses, not a flood of information. Audiovisuals definitely help these patients, and information, education, and communication should be halted if the patient becomes anxious and or agitated or is not in his best frame of mind. And as we are seeing in the last 1.5 years, continuous COVID information bombardment on the news. So that has to be cut down. Only relevant information which is required needs to be discussed. And information overload should be avoided because that really affects their thinking and their state of mind. Interaction with family and friend, regular physical and mental exercise, adequate nutrition and fluid, social connectedness in a very limited way with all the distancing measures, music, group activities, meeting with friends, relatives, and volunteers in a very, very COVID appropriate way. Comprehensive care is very, very important because we have seen psychological well-being comes with physical security and precautionary measures. And it has to be done in a very, very guarded way in this pandemic. And that definitely helps these dementia patients and their special needs. So it has to be a tailored way of managing these dementia patients in this pandemic. For the caregivers, it's very, very important to look after the family along with the patient. So most of them in India take care of their elderly patients at home. You have to stay calm, expect some mood changes in the patient. So you have to look after that. So look for pain, illness, or infection that are the signs of early deterioration. As I said, limit news exposures, stick to positives, look for all these meaningful activities which keeps the brain working well. That is called brain rehabilitation, like a brain physiotherapy, if I may put it. And the family member or the carer has to look after himself. You have to address the caregiver burden. The psychosocial support has to be given. And they need the time for themselves to prevent a burnout. So caregiver health is very, very important if the outcome for dementia care is to be proper. I would just put few slides for the Indian context. As we all know, as we have already discussed, low and middle income countries have a lot of dementia cases, and it's a dual hit on them. We saw probable shortage of ventilators and intensive care in the second wave of the pandemic. That can affect the hypoxia and the intensity of the severe COVID, which can affect the brain health. The COVID waves have hit the patient dementia harder. And we have seen that palliative care has become second priority in this pandemic crisis. It is first to manage the pandemic. So that has really affected the outcome, and that has delayed the potential barrier to diagnosis and early treatment for these dementia patients, because non-essential healthcare services have reduced. It is the acute care of COVID patients which has taken the front seat. And as we have already seen, most of the dementia care is in India is because given by informal carers, family, and mostly women. And it's been work from home for many of the families. Of course, it's a rich and a fulfilling interaction when you are at home and work from home with the family. But for especially for the women, it can become a double shift, personal as well as professional, to look after. Economics are very, very important in India when we are talking about medical care or otherwise. And 80% of the care is by private sector in India. And it's an expensive affair for any average Indian household, 3,000 to 15,000 Indian rupees per month. Pensions and disability benefits are limited. There is poor, inconsistent coverage for patients of dementia and their subsequent problems. Financial constraints, many people have lost their jobs. So economics have to be very, very well thought of when we are managing these patients, and especially when pandemic has added to the problem. We are seeing elderly patients vulnerable for fraud, especially digital fraud, on the rise, and this is seen in India and abroad. So this also needs to be looked after. I mean, we are seeing digital frauds happening with elderly on the phone, and that has really caused a problem. So that itself is affecting the families. We need to subsidize dementia care. And as I was reading few studies from India, there are some national policy for senior citizens along with Ayushman Bharat, who are looking after to make ways to care for the dementia in pandemic more affordable. Government of India, along with the Alzheimer Society, has given support. There is a psychiatric social work team. I think Dr. Ashutosh can put more light on this. They are doing some home visits in some areas of India and seeing whether the patients are compliant with medications and what their problems are. There are advisories and guidelines come out from various centers across India to look after these patients. So if I may put in summary, dementia is in the center stage, and there is a COVID link and a COVID risk. What is the COVID link? Aging, comorbidity, frailty. Patients are more risk, vulnerable patients, dependent patients, increased exposure. So it's a bidirectional association. If these patients are more risk of developing COVID, and dementia patients, and the other way around. Dementia itself reduces the innate and the adaptive immunity, and they increase the risk of COVID-19 infection. So it's a bidirectional relationship between COVID and dementia for the various factors which I mentioned. So I would like to put some take-home messages. COVID-19 pandemic has affected millions globally, and it has changed the way we live. Older adults are more susceptible, patients especially of dementia and chronic health conditions, to COVID. But dementia per se is not a risk factor, as we have seen just few studies. They have mainly problem in adapting and complying to the protective measures, social distancing, masking, washing hands. There is reduced healthcare access because of the COVID isolation, healthcare workers more involved in frontline care. There is limited resource, fear of infection, hospitalization. And because of this isolation, there is more cognitive decline, and it has worsened the behavioral and psychological symptoms. And we need a comprehensive care model where a biopsychosocial approach is required to help these patients of dementia who are really vulnerable. And it has to be a tailor-made effort. Every patient may not require everything. We have to see what the requirement of each patient is and accordingly help them. All this is required to maintain the dignity and autonomy of these patients, help them to remain as independent as possible, and prevent abuse and neglect. And as has been put in one of the study I was reading, aging is considered a stigma, which shouldn't be considered as a stigma. And it has got compounded with this pandemic-related stigma. So these things, need to be looked after, and this has to be seen when we are trying to manage these patients. Thank you.
Thank you very much, Dr. Chabria. It was really an excellent presentation. And as you rightly
Thank
said,
you, sir.
Each patient after COVID has to be followed up vigorously, at least for 6 months, to see maybe there are many other side effects.
Right.
Yeah, exactly. Gone through the ill effects of COVID on
Yes, sir. Right, sir.
psychosocial behavior of a person. Again, we are not having actually any questions, but whatever we have, we'll take into the question panel discussion. Thank you very much, Dr. Chabria. Friends, now we move on to the next topic. Friends, a study has shown that more than 4 out of 10 elderly patients take more than 5 or more prescribed drugs daily. So, does these medications have any detrimental effect on the memory or otherwise on the individual? To talk on this very important subject, we have Mrs. Preeti Chabria, and I request Dr. Kajal Ahuja, Assistant Secretary, IMA CGP Mumbai Sub-Faculty, to introduce Dr. Preeti Chabria.
Dr. Preeti Chabria is a consultant and director of Internal Medicine Department at Sir H.N. Reliance Foundation Hospital and Research Center. She did her MBBS from TN Medical College and Nair Hospital, MD Internal Medicine from Rush University, Chicago, USA. She has many fellowship in lipid disorders from American Heart Association and Gladstone Institute, University of California, San Francisco. She is a diplomat of the American Board of Internal Medicine since 1999. She has been the head of Lipid Specialty Clinic and Geriatric Specialty Clinic at Hinduja Hospital and Research Center. She was a senior physician and partner at the prestigious Permanent Medical Group, that is TPMG's San Francisco Bay Area, California, for more than 15 years. She is the recipient of TPMG Medicine Department Quality Award and Outstanding Clinical Teaching Excellence Award. Her areas of special interest are lipid management, preventive cardiology, comprehensive management of the geriatric patient, multidisciplinary treatment of diabetes, and treatment of obesity. Today, she'll be talking on medications in the elderly, boon or bane. Over to Dr. Preeti Chabria.
Thank you, Dr. Ahuja, for that very glowing introduction. At the onset, a big thanks to Dr. Shah, Dr. A.B. Shah, for inviting me and letting me talk on this occasion on a subject which I'm very passionate about, which is the care of the elderly. Just trying to. Thanks to the IMA for having this webinar today. I have very many stalwarts who have preceded me, so it's tall shoes for me to walk into, but I'll try my level best today. So why exactly are we talking about medications for the seniors? So about 40% of older adults, that's over the age of 65 years, they take more than 5 medications. And as a study in 2011 said, about half of these take even more than 10 medications. And if we were to consider the over-the-counter medications, then these numbers and the prevalence is much higher. What predisposes older adults to have been taking a lot of medications is really because they have multiple medical conditions. And given that if they have multiple specialist visits, that increases their odds of being on many medications. Now, if we see in medicine, really the greatest advances we see are in the scope of medications. Now, just having too many medications, is it always an advantage or is that a disadvantage, is what I'm trying to highlight over the next 30 minutes. I'm just trying to go to the next slide. Okay, what predisposes the adults or the elders to the problems with medications? Firstly, it's normal physiology of aging actually affects the pharmacokinetics from the absorption, which may be altered because of the changes in the mobility of the gastrointestinal tract, to the distribution because of the reduced body water. The elimination of the medications is also affected because of the GFR, which is modified and reduced due to aging. What's particularly interesting is the seniors are more sensitive to medications because of the reduced homeostatic reserve and the greater expression of the receptors, which leads to greater drug activity. That is why there is a general mantra in geriatrics that you start low and go slow. So start with a lower dose, just because of their increased sensitivity to the drug actions. Now let's understand, already Dr. Shah has mentioned a lot about and to very successful way about the medications for the Alzheimer's, but I just want to briefly mention that the various armamentarium we have available for the Alzheimer's. One are the cholinesterase inhibitors. Now what they do is that they help with the acetylcholine deficit by blocking the cholinesterase enzyme, as a result of which there is symptomatic benefit. This, however, does not affect the course of the illness. Now, among these, we have the donepezil, rivastigmine, and galantamine. Now, what I'd like to highlight really is no drug adjustments are needed for donepezil for liver and kidney disease. Galantamine does need to, the dosage needs to be adjusted for kidney as well as liver disease. On the other hand, rivastigmine has great advantage in terms of the patch that has superior tolerability as well as the pharmacokinetics. This does need to be, however, adjusted based on the body weight. Now, cholinesterase inhibitors, about 50% of them show no benefit and really may manifest with side effects, at which point really their efficacy or their use becomes very limited. And has been told before, I'll just quickly go over that they should be taken with remarkable caution in any individual who has history of a sick sinus syndrome or any evidence of bradycardia, because it can increase the risk of syncopes. Memantamine actually has some role in modifying the progress of the disease, because this is neuroprotective in some way, because it blocks the NMDA receptors, which is involved with memory. So excessive stimulation is seen in ischemia. So blocking the receptor prevents further damage and allows the physiological function in the remaining neurons to be restored. And that's why there is an improvement. So in moderate to severe dementia, one does think of an addition of MMT or memantamine with cholinesterase inhibitors. I know Dr. Shah mentioned that this is very controversial, so I don't want to tell what the guidelines are, because those two are evolving over time. But the recombinant monoclonal antibody against the amyloid betas called aducanumab is basically being tried in trials on only those individuals who are proven to be amyloid positive on either a PET scan or a LP. And there are various controversies surrounding this medication. We'll have to see with time how this actually plays out. There has been adverse effects such as microhemorrhages and edema, and serial MRIs are required when this medication is being used. Vitamin E in big doses has been used for mild to moderate disease. However, its benefit in preventing progression is really small, and there is a significant risk with people with cardiovascular disease. However, what's really established is preventing or controlling the risk factors for stroke and cardiovascular disease may actually play a very important role in preventing the progression of cognitive decline. So this is a brief summary about what we have available in terms of medications for dementia. Now let's understand what really medications do and their impact in terms of adverse effects on our elders. Now, our older adults, due to their various coexisting conditions and the fact that they are on so many medications, are specially predisposed to adverse drug effects. In fact, 10% of all hospital admissions in our seniors are due to adverse drug effects. Most commonly, these are due to the oral hypoglycemic agents, insulin, and the antiplatelet drugs. The risk of adverse drug effects also increases with those with renal impairment. In fact, all the students and the residents on my unit, the one thing that they learn is that they absolutely have to keep the eGFR ready on all patients and adjust the medication dosages based on the eGFR. And what is commonly known actually out there is that we do adjust the dosages based on eGFR for the antibiotics. But what I'd like to highlight is that we also need to do that for antihypertensives, the sedatives, and the anxiolytics too. We do need to adjust the dosing there based on the renal function. And creatinine is not an accurate indicator. We do need to calculate the eGFR. Now, what we consider very mild and innocuous medications pose significant challenges for our seniors. And let's consider simple ones that we think of. First generation antihistamines. They are available from any chemist. Any senior can procure them. Medications we use commonly for the bladder, antimuscarinics like tolterodine, oxybutynin, tricyclic antidepressants, dicyclomine. These have anticholinergic effects, which cause a variety of side effects, right from confusion, memory impairment, hallucinations, there may be dryness of the mouth. They can precipitate urinary retention, constipation, an acute angle glaucoma can happen. And more importantly, if they are used long-term basis, such as if the antihistamines or the drugs we use for the bladder incontinence are carried on long-term, they can actually predispose to the onset of dementia. So please, we have a lot of drugs available to us, but everything has to be weighed with the risk benefits. Now, there are several high-risk medications which are potent but pose significant risks for our elders. As I've mentioned, insulin and the oral hypoglycemics, particularly the long-acting sulfonylureas, increase the risk of hypoglycemia. Digoxin predisposes to heart block. Benzodiazepines, there's a greater than 60% risk for falls. Here, I'd like to put in a plug-in. Please avoid the long-acting benzodiazepines such as chlordiazepoxide and diazepam. Severely increased risk of falls for our seniors. First-generation antihistamines, I just talked about them. Opioids particularly can cause confusion, constipation, even respiratory effects. Now, what we use commonly, the fluoroquinolone antibiotics, predispose to tendon ruptures, hypoglycemia, and QT prolongation. So we should be cautious of this, especially if there are other medications on board which can cause QT prolongation. Nitrofurantoin should not be used if the GFR...
Hello, there is some problem with the voice.
Can you hear me now?
It's clear, no problem.
It is clear, yeah, it is clear.
It's clear. No problem.
Yeah.
Go ahead.
Okay. So, and the other one is the cotrimoxazole, where it predisposes to hypoglycemia and hyperkalemia. So if those are the important, very important risks to be taken into perspective when we prescribe these medications. Now, how do we prevent these adverse drug effects is periodically have an overview of all the medications that the seniors take. Allow them to keep medication organizers. What I emphasize with my patients is they should have a list of their medications made on a laminated sheet, which they keep in their wallets and easily available to any specialist or any doctor that they meet. And this is particularly a review of their medication list should be done during any transition, especially when they are transitioning from the hospital to home or home to hospital. It becomes, or changing their care providers. It's very important that these drug lists be looked at and carefully examined. I have my patients bring in their medications every time they come to visit me so that I actually physically look at all the medications they are taking. Now, polypharmacy, this word is actually implies the use of medications more than 5 by a single person. It includes both prescription, herbal, as well as over-the-counter medications. Polypharmacy is particularly common among our elders who have heart disease, lung disease, diabetes, depression, or pain. Now, the impact of polypharmacy is that it increases the risk of drug-to-drug interactions, increases the risk of hospital admissions, increases the risk of adverse drug effects. In fact, patients who have polypharmacy or who take more than 5 medications, their risk of being hospitalized is 4 times higher than those who don't take so many medications. In fact, having too many medications on board increases the complexity of the medical regimen, which also reduces their adherence to medications. And as a result of which, due to several other medications, the important crucial medicines may be missed. And that also brings along its own challenge. Now, I'd like to highlight this one study which was done in Chile, which showed that those seniors who are frail or who have multiple medical conditions like diabetes, lung or heart disease, they have a risk factor. These are risk factors and they are prone to developing or becoming they develop this concept of polypharmacy. They are on multiple medications. But what is interesting in this study is that they showed that this actually impact is bidirectional. So if a person is taking multiple medications, or just the concept of polypharmacy actually increases the risk of frailty. So this bidirectional approach was highlighted in this Chilean study, which makes us realize that polypharmacy brings on an additional risk of frailty amongst our elders. One other concept that I'd like to highlight is called a prescribing cascade, which is when we prescribe one medication and the patient manifests an adverse drug effect because of the medicine. And instead of recognizing that this is an adverse effect of the medication, we consider this to be a new condition and add on another new medication for that. For instance, with a cholinesterase inhibitor, which we use, if they develop urinary incontinence as a side effect of the medicine, many times not understanding that, we consider it to be worsening dementia and then add on another anticholinergic medication for the incontinence. So that just brings on this cascade of treatments. So understanding that adverse drug effect is occurring and hold on and rather back off on one medication is something we should do rather than add on another medication, which actually worsens the concept of polypharmacy. Now, a Beers criteria is something we should avail of and use quite freely. It's constantly or very periodically being reassessed by the American Geriatric Association. This is used to identify inappropriate medications or to encourage certain medications to be stopped amongst our elders, or even before starting medications. It's good to look into the Beers criteria because it gives us a lot of information about what medicines really pose a risk to our seniors. There are those which should be used with caution. Those should be avoided in elders with certain medical conditions. So it's very extremely useful. It also highlights the drug-to-drug interactions. Certain updates, most recently from the Beers criteria, has been that we should not use aspirin as primary prevention in our elders over the age of 70 years, just for the prevention of cardiovascular disease or colorectal cancer. They've also advised to avoid cotrimoxazole if our elders are on ACE inhibitors and ARB, just from the point of view of arrhythmia prevention. And short-acting insulins are being discouraged amongst our elders. So even some of the over-the-counter medications can be inappropriate among the elders. So therefore, this Beers criteria becomes really useful to review and check before we make certain drug adjustments with our elderly. There are other criteria also which are less used, but they are also equally useful. There's something called a stop criteria, some called the start criteria, which actually highlights certain medications which are useful for elders with certain conditions. So we have a lot of help out there. We just have to utilize them to provide optimal care and services to our elders. For example, we may find that the medication is a duplicate prescription of another from the same class. So that helps us to stop that medication. These these criteria will go a long way in safely prescribing medications to our elders. Now, the American Geriatric Society has made certain recommendations in terms of drugs for our elders. One general rule of the thumb is we should not add on any other medication without doing a thorough review of all the other medications that our elders take, including over-the-counter medications and dietary supplements. For insomnia, an antipsychotic to be used as a first line is strongly discouraged. Now, one very important thing which has come out of the Geriatric Society is that we don't have to push for aggressive diabetes control among the elders, because we do need to understand and individualize their treatment based on their risk for hypoglycemia. So there is a concept which is quite widely accepted in the geriatric societies, is the acceptance of permissive hyperglycemia, where the HbA1c goals can be from anywhere from 7.5 to 8.5, which has to be individualized, basically to reduce the risk of hypoglycemia and all the problems associated with it. With the goals of treatment, I'd like to share with you one of my own patients and how we established what polypharmacy can do to our elders. There was this 81-year-old woman. She had multiple medical conditions: diabetes, hypertension, dyslipidemia, dementia, arthritis, heart disease, and osteoporosis. Seems like one of the very common elders who can walk into your office. But at one point, she had clearly told me and her other providers that her goal in life was very simple. She wanted to continue to be doing her embroidery, her knitting, and meeting her grandchildren, sorry. And that was what her expectation in life going forward. When she first came to me, she was on 19 different medications, which was compounded by all her visits to the various specialists. And when she came to me, her caregiver very proudly showed me that her HbA1c was 6.5. But this lady had become unsteady on her feet for the past 3 months, and that's why they were seeking care with me. When we looked at all the 19 medications and her aggressive sugar control, we slowly started weaning her off the medications. And within a month, her balance improved, her mood improved, and she was really happy because she was able to now independently go and visit her grandchildren. So this is just to highlight what polypharmacy can do and how we have to individualize the treatment for our elders. Certain specific drug classes which I'd like to mention about is, which plays a role especially for our elders, and we have to use with caution, especially the statins. Over the age of 85 years, their risk-benefit ratio goes more in favor of the risks. So we really need to revisit all statin use over the age of 85 years. If their life expectancy is reduced, there's not much that a statin can give us. Over the age of 70 years, what we've realized is dyslipidemia is not the major factor which impacts all-cause mortality or the cardiovascular disease mortality. In fact, in 2013, the American Heart Association recommended that statins in people over the age of 75 years as a primary prevention should only be done after a risk-benefit analysis, and drug-to-drug interactions have to be looked at, and the patient preference has to be taken into account. This is a new concept, which is now, I never knew in my lifetime I would see this concept, but it's called De-Prescribing. We really have to look at the various medications and several ones which are from multiple drug classes. We really have to think about slowly reducing them or stopping them. This poses a challenge too. It's not easy to do that all of a sudden, especially if people have been on them for a long period of time. And particular care has to be done among the antidepressants, as well as the medication used for reflux, gastroesophageal reflux, because this leads to the upregulation of the receptors. So they have to be slowly weaned off because otherwise symptoms can recur. But this is a very popular concept, and hence I'm throwing it out there among the geriatric population. It's something that is going to gain a lot of steam in time to come. I'll skip this slide. Now, in terms of the best prescribing practices, which I'd like to highlight for all our elders, particularly those with dementia, every medication that we add on, we have to assess their risk-benefit ratio. We need to think about the time to benefit of the intervention. Does the senior have that kind of time where we will actually see the benefits of the medication? Periodically, we need to reassess whether each medicine needs to be continued. We have, the seniors, the reason I like treating them is they are the best patients. They follow every word that you tell them to the T. And here I see patients carrying on with their medications for years to come without questioning them. I've found people on dual antiplatelet drugs much after the necessity of those was established. So those we have to periodically reassess. What I find is the best practice is when we prescribe upfront, I like to tell the elders or their caregivers how long we anticipate the medication to continue. Whenever we prescribe a medication for an elder, we want to start with the lowest dose and increase the dose very gradually. Consider any non-pharmacological intervention instead of medications. Take into consideration a drug cascade as a potential adverse drug effect before jumping into treatment for any new symptom. Always, if we are thinking of adding a medication, think about whether we can stop any other medication which may be duplicating that particular medicine. Try to simplify the dosing schedule. It may not be optimal in terms of drug absorption, but if we can group the medications together, it's always better and also helps to organize their pill box much easier and a safer method. And each medication, when we add on, the patient as well as the caregiver should be clearly explained what the medication is for, what is the advantage versus disadvantage, and when we can think about stopping it. So once again, our first goal is do no harm. While we have several medications, I just wanted to highlight the impact and the risk of polypharmacy. Thank you once again for your time and attention.
Thank you very much, Dr. Preeti Chhabria. As we have decided, we'll take the questions during panel discussion, but I'll just ask one question, which I find very important. What precautions should be taken in prescribing HIV drugs? Because the person has to take them lifelong.
Yes. Those are, again, they add to the polypharmacy, and that's why the drug-to-drug interactions, they have to continue. But there too, the guidelines keep changing. So basically, we have to kind of keep, when we add on any other medication, again, use the Beers criteria, which has been established. There is mention of the antiretroviral therapy there too. So we can use that to assess for drug-to-drug interactions. Excellent question.
Thank you, madam.
I'm just trying to get off the screen.
Dr. Hitesh wants to ask some questions.
Well, the de-prescribing concept is very nice and very useful and very essential in these days with so many drugs coming into the market.
And what we have seen in day-to-day practice is that a consultant who writes small number of medicines is supposed to be a good consultant. That is what we have seen. Many prescriptions we see with, are 9-10 drugs given at a time, as you said. So,
yeah, that's increasing the risk. And that's why this concept of de-prescribing is going to now see the light of the day.
yeah. Thanks a lot, madam, for excellent presentation. Friends, now we move on to the next topic. The next speaker is Mrs. Shraddha Shah. Madam is already there on the panel. I request Dr. Sarita Devi, who is a member of IMA CGP Mumbai sub-faculty, to introduce Dr. Mrs. Shraddha Shah.
Mrs. Shraddha Shah is a psychologist specialized in neuropsychology. She is consultant psychologist at Sir H.N. Reliance Foundation Hospital and at Jaslok Hospital and Research Center. She founded Synapsium Brain Health Clinic to provide superior clinical psychological and neuropsychological services to adults and the elderly in 2013. She also teaches neurocognition to students doing masters in psychology at the SNDT University. After completing her bachelor's in neuroscience from Hamilton College, New York, she pursued a master's degree in clinical psychology from SNDT Women's University. She continued her training in neuropsychology at KEM Hospital, Mumbai, and is currently a PhD scholar conducting research in area of positive neuropsychology. She strives to bring newer therapies of neuropsychological rehabilitation through continued learning from international faculty and training experiences such as the Rusk Institute for Rehabilitation, New York. She is a fellow of the Indian Association of Clinical Psychologists, Indian Federation of Neurorehabilitation, World Federation of Neurorehabilitation, Indian Epilepsy Society, and Indian Epilepsy Association. Ms. Shah has presented her research at various conferences. She has a special interest in neuropsychological rehabilitation for brain injury. Today she will be talking on role of neuropsychology in creating a neuroprotective lifestyle. Welcome, Ms. Shraddha.
Thank you, Dr. Sarita, for that introduction. And to just start off with, thank you, Dr. A.B. Shah, for inviting me to speak today. And of course, to the IMA for organizing this webinar to celebrate World Alzheimer's Day. I am very happy to be invited and to be speaking about something that I am so passionate about, which is creating a neuroprotective lifestyle. I am just going to share my screen. All right. Okay. So once again, my topic is to describe the role of neuropsychology in creating a neuroprotective lifestyle. So there's a couple of terms in there that I'm going to begin by describing first. So what is neuroprotection? Neuroprotection is any sort of intervention that aims to inhibit the pathogenic cascade that results in cell dysfunction or in cell death. So anything that we do to prevent neuronal cell death and to preserve function of the brain, that is something that is neuroprotection. And we have heard all of the previous speakers give us really good information and detailed talks on dementia. And of course, Dr. Joy Desai also described cognition and lifestyle. And so I think there's going to be a bit of an overlap between what Dr. Desai and I are going to talk about. I will be focusing a little bit more on the role of a psychologist in this. So what do we need neuroprotection from? All of us need protection from advancing age, whether we have any of the other risk factors or not, but advancing age is something that none of us can deny. So when the interest in preserving our health, preserving our brain's health began, the understanding started with these 4 factors, and these 4 factors are the best understood even today. If we were to add one more factor to it, cognitive engagement is the next best understood factor and the most prescribed after. Healthy diet, physical activity, sleeping well, and also maintaining the metabolic parameters, some of which Dr. Preeti Chhabria was talking about right now. So let's just very briefly understand what is neuropsychology. Neuropsychology is the study of different brain functions, cognition being one of them, but emotional behavioral functioning and your psychosocial relationships also fall within the purview of neuropsychology. If I was to describe what a neuropsychologist does at present, most of the time, the role is extremely clinical, and it is to evaluate cognitive dysfunction and possibly to rehabilitate the cognitive dysfunction in brain injuries, in stroke, in dementia. However, what we need to look beyond now, what we need to look to is beyond just clinical neuropsychology and to something known as positive neuropsychology. So should the role of neuropsychology primarily focus only on documenting cognitive dysfunction or promoting cognitive health as well? Neuropsychological assessments are extremely long, lengthy. They can, the test battery can last up to 4 or 5 hours. So it's reasonable to expect that some form of positive news or interventions can be recommended and should be recommended after these many hours of assessments and diagnostic labels. So a neuroprotective lifestyle, the understanding today with all of the research that we have available is that it should also include stress management, healthy social interaction, meaning and purpose in life, which Dr. Joy Desai also referred to as enthusiastic passion and leisure activities like that. And we saw his sketching possibly as an example. And lastly, mindfulness as a treatment, but also as a lifestyle practice for prevention. So why must one adopt a neuroprotective lifestyle? In 2017, there was a Lancet commission that that found several different risk factors which affect us in at different points of our lifespan, and several of which are modifiable. And these potentially modifiable risk factors can be mediated, and we can intervene very early in life. Studies have also shown that the brain starts to age in its 30s, which means that it is a time-bound and a time-intensive lifestyle change that we should be aiming for. The NUN study, which Dr. A.B. Shah mentioned as well, it was one of the initial works which began in 1986, which sparked the interest in neuroprotection. And it's a longitudinal study, and it's given us decades of data, and it continues to do that. But one of the main takeaways is that cognitive impairment is not an inevitable consequence of aging. That's the main takeaway, and it was an eye-opener for a lot of people. But this awareness still needs to permeate all of the levels of our Indian society. One of the other reasons why we should look at a neuroprotective lifestyle is neuroplasticity. There is immense data for that. and the ability of the brain to restructure itself has given rise to something new, something known as the neural reserve. It's a concept that, like a bank reserve, we can continue to add to it. We can continue to build on the amount of resistance that our brain can have. Sorry. On the amount of sorry. Sorry about that. Apologies. So a neural reserve is like a bank reserve, and we can continue to add things that can sort of cushion the damage that might come through because of brain injuries, or because of aging, or because of several other risk factors that we might be prone to. There are several positively associated factors like education, or so that's formal education, bilingualism, physical activities, eating healthy, as well as additional data in recent years that show that social and leisure activities can also add to your neural reserve. So essentially, the neural reserve is, it refers to a concept that is an inter-individual difference in your cognitive processing that exists in any normal, healthy brain. However, that concept has now been extended to actually look at brain pathology also, and how you might need to cope with different brain pathologies. So what we know today is that the higher lifetime of cognitive activity that we have had and higher physical activity is associated with fewer white matter lesions, which results in higher global cognitive functioning as we continue to age. Environmental enrichment, once again, is something that helps with environmental enrichment is something that helps in improving the neural cognitive reserve. And what we know is that your lifestyle activities spanning several decades can be the most useful. So starting early is one of the key conclusions. Neuropsychology, as we understand it, it brings a gamut of cognitive, emotional, behavioral, and psychosocial interventions. And I will be presenting why and how we need to include these in our lifestyle. So a study that was conducted, this particular research project won the Nobel Prize. It was conducted by Dr. Elizabeth Blackburn and her colleagues, and it won the Nobel Prize in genetics and physiology in the year 2009. They published a book on it called The Telomere Effect, and they highlighted several different interventions based on risk factors that can impact the length of our genetic makeup. And the telomeres are, so there's a little cartoon that I've shown to the right of the slide. The telomeres, as most of you know, are the ends of the DNA which continue to shorten as we age. However, there are different risk factors that impact the pace at which the shortening happens. And based on that, there are different recommendations that have been made and different lifestyle changes, various different lifestyle changes that can be added, which can reduce the pace at which this shortening takes place. So in the book, they highlighted something that was previously thought to be extremely vague and misunderstood. They identified 5 different types of thought patterns. When we talk about emotional health, We know that neuropsychiatric disorders like anxiety, depression, bipolar, OCD, all of these need to be, we need to be safeguarded against them to live healthier lives and to live cognitively stable lives. But what they did was they actually identified 5 thought patterns which very specifically lead to the shortening of the telomeres and therefore reduce our age span as well as our health span. So how long we live healthily. Both of the things actually are affected by these different thought patterns. So cynical hostility is how angrily and how against everybody you live. Pessimism is the constant sort of worry of something negative happening. Mind wandering is when you're engaging in maybe banal activities of everyday life, but your mind is elsewhere, so not being present. Rumination is the constant rehashing of a problem over and over again. Again, one of the symptoms of anxiety. And thought stopping, which is avoidance of something that is maybe bothering you. And all of these actually have been linked to possible cognitive dysfunction. Another area of research is the quality of relationships that we have. That plays and how long these relationships continue in our lives. This plays a role in how healthily our brain continues to function as we age. So all of the different cognitive domains, some have been associated more so than others with the quality of your relationships. There's also been specific research that has shown that older adults with greater levels of social engagement fare better than no social activity at all. Another very important study was to show that a lifetime participation in socially stimulating activities has better impact than starting later in life. Once again, telling us repeatedly that we need to start early and we don't need to wait until the 50s or the 60s to begin. Today, even the 50s are thought of as starting early. However, research is showing that we need to start a couple of decades sooner than that as well. A sense of purpose in life, finding meaning in what we do. This is an executive function and very clearly mediated by the frontal lobe. It is very closely related to metacognition, and it's a great technique for coping with stress as well. So one of the indirect means to actually regulate the HPA axis is to find meaning in what you do and to find a clear purpose in life. This is something that has also been implicated in possibly influencing longevity. There was a book a few years ago that became a bestseller called Ikigai, and which was very closely based on this. So they studied centenarians from the country of Japan. And what they found was that on the island of Okinawa, apart from other differences, everybody had a sense of purpose in life, and that is possibly related to having them live such long lives. So without a purpose in life, there is emptiness and anxiety, which is very closely associated with major depressive disorder. But with it, there is satisfaction in life, pleasure, ambition, and this actually persists even in harsh environments. So despite what is happening around us, having a purpose in life can continue to support us through these difficult times and make us more resilient, which is something that we can use a lot more of, especially today. This has been an interesting field of research. Very recent in the last couple of decades, actually, a lot of research has come up related to negative stereotypes. So there are stereotypes related to aging, and what we call certain kinds of ageist jokes. This is something that impacts older adults' cognitive ability, physical health, and overall sense of well-being and functioning. There have been studies that show that people who hold negative stereotypes about aging also perform poorer on memory tests and show greater decline. Older adults with negative attitudes are also shown to experience possibly more psychosocial stress, and they have several different cardiological risk factors and disorders that they can suffer, including heart failure, infarct, strokes, and they thereby also have a lower life expectancy. The inverse of that is that interventions that are very clearly designed to create awareness and to educate the community about truths about aging, they have been successful and they have improved the well-being of older adults. So targeting negative stereotypes is another very clear factor that can help improve cognition as well as overall well-being in older life. So psychotherapy as a treatment. This is something that I know for neuropsychiatric disorders is quite well understood. However, I'm going to be talking about this for aging and how it can play a part in a neuroprotective lifestyle. So just very briefly to explain what psychotherapy is, it's a process in which a psychologist uses certain theories that have come about from studies related to human behavior, developmental stages of the brain as well as the body, including lots and lots of studies related to physiology as well. And the goal of psychotherapy is to help an individual modify behaviors to actually achieve the goals that they have set for themselves in their life. These goals are individualized and can include anything from stress management to feeling happier and coping with anxiety or depression, to building motivation towards achieving the goals that they have, finding purpose in life as well through self-awareness, better self-compassion to create better resilience. All of these different goals, how are they related to everything that we talked about? That's something that I'm going to now discuss. So we talked about emotional health. We talked about how people can be cynically hostile, how they can be pessimistic. So one of the clear solutions for that is to build resilience, is to build optimism, is to build gratitude in one's life. And psychotherapy can very clearly help with that. Building better relationships, as we talked about, also comes through better emotional regulation, better communication, which is also a goal of psychotherapy. The last that we talked about was negative stereotypes, which come in through better awareness models, as well as through psychotherapy to help cope with the stigma that is associated with aging. Cognitive engagement, which is something that we briefly mentioned and that has been mentioned earlier. There are several studies to show that older adults, if they begin even later in life to practice cognitively stimulating activities. Now, what makes a cognitively stimulating activity most beneficial is if the activities are constantly diverse, and the diversification is based not on the format or the stimulus, but on how many different cognitive domains it exercises. So a few years ago, Sudoku became all the rage, but Sudoku only actually exercises problem solving, numerical ability, and not language skills, for example. So what we need is different kinds of activities which can exercise every single part of the brain, loosely speaking. Something that is more relevant to everyday life rather than just sitting with puzzle books or sitting on the sort of laptop or iPad trying to use different skills, different websites like Lumosity. Activities of everyday life and including interaction with other people. There was a study done for this, which was a community-based intervention program where they had older adults supporting children in their studies. And there have been certain instances where in and around India, there have been old age homes that have been constructed right next to orphanages where the two support each other. And examples of these community support systems have actually been studied and have shown that they can provide improvements in cognitive functioning as well as emotional well-being. So sustained engagement in cognitively demanding novel activities can improve neural efficiency. Novelty is the key, and challenge and demand on our cognitive functions is another added benefit. So trying to learn different skills, maybe a new instrument, maybe a language, these are things that we sometimes recommend to our clients and our patients, but also understanding where and why they come from. So all of this is in line with harnessing neuroplasticity to actually improve our neural reserve. Cognitive stimulation, as I explained, can be used as a therapy, as a treatment by involving several different domains of cognitive function, adding engaging leisure activities into one's routine, and doing it as consistently and as regularly is most important. So there are two parts to everything that has been said. One is starting early on and allowing the decades and the years to actually show impact. And the second is to add in as much as we can the closer we get to aging. So cognitive remediation, reminiscence therapy, behavior activation therapy, these are therapies that can be added as we continue to age. Whereas a neuroprotective lifestyle would actually need to include the first 2 points as mentioned. Sleep has been discussed in detail by Dr. Joy Desai. So just quickly summarizing, the glymphatic system, as he very well explained, it removes beta amyloid and tau deposits, which we know are implicated in putting us at risk for dementia. It improves memory consolidation, better quality and adequate quantity of sleep also is implicated in having longer telomeres and vice versa. Poorer sleep, so fragmented sleep or sleep disorders are implicated in shorter telomeres. Good sleep quality is also associated with better immune function, insulin, obesity, as all of you know. And this has been explained. So, sleeping well. Sleep hygiene is something that can be recommended and prescribed as treatment. There are certain countries where sleep hygiene as well as mindfulness meditation are now acceptable treatment forms that can be prescribed by y'all, the medical community. Behavior modification, which is a technique in psychotherapy, can also be used as treatment to help patients sleep better and to include sleep hygiene techniques into their everyday life. Mindfulness meditation. Slide has a little bit of information, but to explain very simply, some of this also was covered actually by Dr. Joy Desai, where he spoke about the anterior cingulate cortex as well as the prefrontal cortex. And studies have shown that the cortical and subcortical volume, as well as neuronal density and synaptic plasticity, all of these can improve in the anterior cingulate, in the prefrontal cortex, as well as the amygdala, to provide some of the benefits that are listed on the right. With a regular practice, year on year of mindfulness. There have been some studies recently that have been published, which have shown that a 20-year regular practice of mindfulness meditation can lead to a 50 or 55-year-old having the cortical thickness in the prefrontal area of a 23 and a 24-year-old. So regular practices of mindfulness improve cognition across domains of attention, working memory, problem solving, memory, of course, as well as creativity and naming functions within the language domain. It also helps improve self-awareness, and which means that it can help us set realistic goals, help us reduce stress and reduce anxiety. It improves our psychological resilience, which is something that we're talking about as one of the foundations of a neuroprotective lifestyle. Improves sleep, improves pro-social behavior, and something that we are now starting to understand more and more about is the default mode network, which is the chattering monkey mind, as we loosely call it. When our mind is wandering and not focused and stressing over things from the past or worrying about the future, the default mode network is in control. And a regular practice of mindfulness can help quieten the default mode network. There are different activities apart from just mindfulness meditation or activities of meditation that can be called mindfully healthy. Yoga, pranayam, tai chi, mindful eating, and intermittent fasting. There are various grounding techniques that we teach in psychotherapy as well. Even certain forms of religious chanting are mindful. An experience of flow, which is a positive psychology concept. I don't have the time to get into it. And activities of leisure, such as juggling. These are also mindful practices. So adding these into our everyday life consistently with hard work helps us create a neuroprotective lifestyle. And a lot of interventions are needed to regulate the HPA axis, some of which have been mentioned by me, and a lot of them have been mentioned previously by the other speakers. And what we need to do is shift our view from resolving pathology and waiting for dysfunction to appear, and take a step back and create a preventive healthcare lifestyle. The role of neuropsychology, as I mentioned, is a combination of cognitive intervention, emotional behavioral intervention related to psychotherapy, and psychosocial functioning. Thank you so much, everybody, for listening.
Thank you very much, Dr. Shraddha. It was really an excellent presentation. Neurocognition is your topic of interest, so you have given a good insight about all the cognitive disorders.
Do we have any questions?
Yes. Yes, Dr. Jitesh.
Yeah, you can ask.
वैशाली गैस धीमा कर देना.
You want to ask Dr. Jitesh?
No.
No. Okay. There's a request from many of the doctors that can we have the presentations of this program. I want to tell everyone that this program is on YouTube for many days. They can go and log into YouTube and can see the lectures again, and they can see the PPT presentation also. So just log into YouTube, and then you may type the IMA lectures, and you'll get all those things on YouTube. Okay. So now we move on to the next topic, and that is a panel discussion. We have four panelists: Dr. Arun Shah, Dr. Preeti Chhabria, Dr. Ashutosh Shah, and Dr. Ashish Contractor. I hope Ashutosh and Contractor sir is there. Yeah, they both are there. The topic of the panel discussion is basically a prevention. There are two people, two doctors whom we have not introduced. I'll just introduce Dr. Ashish Contractor in short. Yeah. Dr. Ashish Contractor is head of the Department of Rehabilitation and Sports Medicine at Sir H.N. Reliance Foundation Hospital. He had the distinction of being part of the team which treated the Prime Minister of India, Dr. Manmohan Singh, after his redo bypass surgery in January 2009. He is widely recognized as the pioneer of cardiac rehabilitation in India. He completed his graduation at the TN Medical College, Mumbai, and post-graduation at the University of Virginia, USA. He was further trained in the United States under the leading experts in this field. He is the Vice Chairman of the International Council of Cardiovascular Prevention and Rehabilitation. He has served as the Certification Director of the American College of Sports Medicine in India since 2003. He is an avid sportsman himself, having run several marathons, and has been the Medical Director of the Standard Chartered Mumbai Marathon for almost 11 years. The Zoroastrian Trust Fund of India awarded him the Outstanding Zoroastrian in Medicine in 2016. He wrote a book on preventive heart care for lay people, The Heart Truth, Everything You Wanted to Know About Prevention, Treatment, and Reversal of Heart Disease. Dr. Ashish Contractor will be the part of this team. The next person who is with us is Dr. Ashutosh Shah. I request Dr. Sarita Devi, who is a member of IMA CGP Sub-Faculty of Mumbai branch, to introduce Dr. Ashutosh Shah.
Yeah. Dr. Ashutosh Shah is a consultant in the psychiatry department at Sir H.N. Reliance Foundation Hospital and Research Center. Dr. Ashutosh Shah completed his MBBS in 1996 from University of Mumbai, followed by DPM and DNB in psychiatry medicine. Dr. Shah has worked at many prominent hospitals in the city and holds lifetime membership of Indian Psychiatry Society, Bombay Psychiatry Society, General Practitioner Association, and Indian Society for Clinical Research. He has authored 5 publications and has undertaken 2 clinical research projects. His special interests include mood and anxiety disorders, schizophrenia, and dementia. And Sir prefers to call himself as a practicing student of psychiatry since 1999. Sir, welcome you here.
Okay, so friends, we have 2 more panelists joining this session. We'll start with the panel discussion, and on our side we will have
Dr. Anil. Since other speakers are also there, Dr. Joy Desai is also there. Whatever questions pertaining to these lectures, they can also be asked.
Yes. Right. Even Dr. Shraddha is also there with us. So questions can be directed to any one of the speakers who are with us since morning. Sir, the first question from my side goes to Dr. Ashish. Dr. Ashish, can you tell us about the role of physical exercise in preventing Alzheimer's disease? Does it have any benefits in healthy aging?
Thank you, Dr. Awad. Let me thank Dr. Arun Shah. Let me thank the IMA for organizing this absolute wonderful seminar on a Sunday morning to commemorate World Alzheimer's Day. We've had over 500 participants, which itself is a tribute to the excellent program put together. I enjoyed listening to the previous speakers. Every time Shraddha talks about mindfulness, I remember that I've promised her that I'm going to be doing it for the last several years, and I've still not gotten down to it. So to answer your question in one simple word, yes. Both physical activity and exercise are very beneficial, both in the prevention and treatment of Alzheimer's disease. In fact, there was a lovely review paper which Dr. Shah very kindly shared in 2020 by a group of Spanish authors. And in that, they found that in a meta-analysis of studies looking at over 160,000 participants, the ones who were more physically active, the ones who exercised more, they reduced their risk of developing Alzheimer's disease by almost 45%, which is fantastic. All of us as physicians, both for our patients and ourselves, understand that quality of life is very important. So the idea is to maintain a healthy quality of life till the end. And what normally happens is the last decade tends to be declining. So regular physical activity and exercise. And again, when we talk about exercise, it does not mean you got to spend hours and hours at a gym. It could mean something as simple as taking a 30 to 40-minute daily walk, just being more active around the house, taking more steps as the days go by. Exercise has also, shown to increase cerebral blood flow, increases neurogenesis. Earlier we used to think that our brain cells just, do not multiply as we age, but we realized that there are 3 factors which help in neuronal generation even as we're growing older. 1 is exercise, 2 is healthy eating, and the 3rd is a lifetime of learning and doing different things. And I must make a point that Dr. Arun Shah is a great example of someone who's always continuously learning and doing different things. So I think that is very important. Exercise has also been shown to lengthen the telomeres. As Dr. Shraddha mentioned, those are shown to extend life. So to answer your question, yes, exercise is an extremely important part of your lifestyle, both for prevention and treatment of Alzheimer's.
Dr. Ashish, can I ask a question?
Please, sir.
So is there a role of regular checkups in seniors? Like how important it is to screen the senior citizens as far as Alzheimer's is concerned?
So from an Alzheimer's screening perspective, I'll just quickly answer it from a rehab exercise perspective, and then I'll pass it on to Dr. Preeti to talk more about are there any diagnostic checkups you need to do. So what we do when someone comes to us in the department, and we work very closely with Dr. Preeti in our geriatric department, is we do a general musculoskeletal screening, because as they are aging, there's also muscle loss and there are higher risk for falls. So we do a clinical balance assessment, and we also do a musculoskeletal screening to look for risk for falls, and then we give them a prescription based on that. So Dr. Preeti, is there a role for diagnostic workups in your opinion?
So in terms of, the way, absolutely, there is a role. In terms of what we look at it is just look at geriatrics as the other end of the age spectrum from pediatrics. So just like we take our kids for regular checkups to the pediatrician to establish developmental milestones, to see if their health is improving and they're growing at a correct pace. On the other end of the age spectrum, our older folks too need to be taken regularly for checkups to establish how their mood is, how their memory is progressing, how their mobility, what you all do at your excellent department, Dr. Ashish, how if there are problems with their micturition, with their urinary control, then importantly also to assess for the immunization status, if those need to be updated. So variety of things that have to be looked at periodically, and that's why the periodic health checkups for our elders is crucial and very important.
Thank you.
Dr. I would request you to please conduct the further proceedings of this discussion.
Thank you, sir. So I'll also encourage participants. We've got a Q&A, so please put in your questions in the Q&A. If you want to ask it to a specific panelist, you can put their name. Otherwise, we'll direct it generally. So I noticed there are questions related to depression, both being a risk factor for dementia and how does treatment mitigate it. So I'd like to pose the question to Dr. Ashutosh Shah. Dr. Shah, could you talk to us about the sort of the linkage between depression and dementia, please?
Yeah. Sure, Dr. Contractor. And before I address your question, would like to thank Dr. Arun Shah and IMA for making me part of this wonderful meeting. So coming to the question, depression. Now, depression can occur in three contexts when we are saying about dementia. One, it can precede the onset of dementia and be a true risk factor. That's first. Second, it can be the first symptom, the non-cognitive symptom of the onset of a neurodegenerative disorder. And third, it can occur later during the course of an Alzheimer's disease. Now, irrespective of when it happens, we know that comorbid depression and dementia tends to accelerate the onset of neuroprogressions. That means in so-called quote unquote normal individuals, it tends to promote the onset of minimal cognitive impairment. And then subsequently, those who are having minimal cognitive impairment, it tends to accelerate development of dementia. So definitely, meta-analysis has shown that depression tends to double the risk of developing dementias. And therefore, some authors believe that it could be having a causal etiology. Not only causal etiology, there could be a reverse etiology. That means depression is a symptom of dementia first presenting rather than being causing dementia in certain cases. Now, what certain studies have shown that even depression occurring in early life. So depression usually is a disorder of the young, not the middle age or the elderly. Some studies have shown that it is associated. So when I say associated, it's a statistical correlation, not a causal association with dementias. But some other studies have shown evidence to the contrary and say that only depression occurring in late life would be a risk factor. So there is conflicting evidence. Now, what is also known that depression, when it is severe, tends to increase the risk of dementia and the number of episodes of depression. So depression is a recurrent disorder. Each episode tends to increase the risk of dementia by approximately 14%. And untreated depression and those having difficult to treat depression, previously known as treatment-resistant depression, these individuals are also at an elevated risk. So there is a very close link between the two disorders. In general, depression is seen in about 32% of people with minimal cognitive impairment, or between 25 to 30% in those with dementias. Now, even in this, the vascular dementia are more likely to have depression, almost up to half of them. And the unspecified dementia is up to a third, and lesser, only up to 20% of Alzheimer's may have comorbid depression. Now, when we are seeing all this data, the exact mechanistic link between depression and dementia is not yet completely known. But we know certain biological mechanisms, the most prominent one being the HPA, that is the hypothalamic pituitary adrenal axis, and what Dr. Joy Desai said about glucocorticoids. So, glucocorticoid levels, they tend to have effects on the amyloid precursor protein, beta amyloid, even phosphorylation of the tau, and that causes damage. So in untreated elderly, structural MRI studies have shown shrinkage of the hippocampus. So this is something known to happen even within dementia. Other than this, both dementia and depression are chronic low-grade inflammatory conditions. So, now with COVID, everybody is familiar with the words cytokines, CRP. These are in general elevated in those with depression, and they bring about certain what we call the damage to the neuronal architecture, including damages to the astroglial cells also. And finally, the nerve growth factors like BDNF, these tend to go down, and they are involved in neural regeneration synapses. So long story short, depression is definitely a risk factor, even from a biological perspective, and should not be underestimated. Now, coming to treatment, that was the second part of your question, Dr. Contractor. How does treatment help? So I go back to what Shraddha had shown in her presentation, where the Lancet Commission in 2017 had shown that modification of risk factors lowered the risk of having dementia by up to 30%. And if we tease out over here, treating depression reduces the risk at population level by up to 4%. That's a huge compared to controlling hypertension, where it is risk up to 2%, or with diabetes, 0.8%. Or if we look at even physical inactivity, which you were speaking about, when we address that, it reduces the risk at a population level by 2.6%. How exactly does it happen? So the popular myth is antidepressants will lift the mood and elevate depression, but there are other mechanisms. So anti-inflammatory action is a well-known effect of all antidepressants. And within the antidepressants, SSRIs are the most commonly prescribed medicines, and they have anti-inflammatory actions through various molecular pathways, which I won't detail over here. Secondly, even phosphorylation of tau proteins is tended to be prevented. Of course, this is coming from animal experiment data, and escitalopram has shown to prevent phosphorylation of tau proteins. Other thing is they have neuroprotective action, increasing BDNF. And also what we know is the antidepressants tend to reduce the beta amyloid levels. So in human studies, they have done this experiment to measure the beta amyloid levels in the CSF, one placebo group, one citalopram group, and 40% reduction of the beta amyloid in those given citalopram. So a neuroprotective action of antidepressants was shown. And very few studies which have followed up longitudinally people on long-term SSRI and that their conversion to MCI or to dementia. And there was a delay when people were prescribed SSRIs for a long term. So this is what I can say about depression and how we address to reduce the risk of dementias.
Thank you so much. I think depression and even cardiovascular disease has sort of a very similar two-way symbiotic equation. Thanks for that. One of the questions in the chat box is about prescribing HIV drugs in the elderly. So if I can request Dr. Preeti to take that. It says that what precautions should be taken to prescribe HIV drugs in the elderly, especially since these have to be taken lifelong.
I think thank you for that question. I think it's very important because this is again as now established as a chronic health condition, and it's not something that you can take lightly. They have impact on the cardiovascular health, and the lipid metabolism is also altered by the protease inhibitors. So it's actually quite a challenge. So what I would recommend, as I alluded to before too, is to take the help of the Beers criteria, which is maintained by the American Geriatric Association and modified periodically. When we add on those, the protease inhibitors or the other anti-HIV medications, we look for drug-to-drug interactions, and what additional medications should be added on. So it's a very comprehensive set of criteria which will facilitate the treatment protocols for addition of those multiple medications.
Thank you. If Dr. Joy Desai is there, I would like to address the next couple of questions to him. Dr. Desai, the question is, what about interrupted sleep in the elderly because of conditions such as, BPH, etc.? How do you deal with these problems? And do you resort to hypnotics for interrupted sleep? And there was one more which I'll just add in. It says, which is the best drug to be prescribed for insomnia in the elderly?
Yeah. Okay. So thank you. I mentioned in my presentation about the 6 or 7 month old study, which is a large comprehensive assessment of sleep duration in its entirety in middle life and its relationship to the risk of evolution of dementia in older life. And clearly 6 hours or less, so the moment you go to 5 hours of sleep in your middle life for a prolonged period of time correlate with a 30-40% higher risk of cognitive impairment as an older person. There are numerous other tenets of scientific evidence to correlate what sleep fragmentation does. So the key question is that as you're growing older, your sleep is getting broken up into numerous chunks of sleep because of either waking up often, or you have a bladder issue and you go to you have to use the washroom often, or intrinsically the sleep architecture is exhibiting a not a good depth of deep sleep. Now, I also noticed that in the two conversations we had a few minutes ago, when somebody asked about prevention and what are we doing in our health checks, nobody's discussing are we doing sleep assessment in our health checks. And that has to be the next frontier. Because if you're going to protect our middle-aged and the elderly, we got to have a screening process to understand how they're sleeping. Because A, we have evidence of sleep and health. B, you're spending that 1/3 of your time in 24 hours, and we are only assessing how they're running on their treadmill and doing their biochemistry. If one understands how does one improve sleep depth, well, there are a lot of studies to show that elderly people have a declining melatonization of their sleep onset. That means when they go to sleep, they are making much less melatonin than younger people as a kind of elderly failure. And melatonization paucity, that means lower melatonin levels in your sleep, leads to more arousals. You're waking up more often. So I personally think one of the things to understand is that we should tend to use a hypnotic, which is not a true hypnotic. So I prefer to use melatonin as an adjunct for all my elderly people who say that I have difficulty falling asleep, or doctor, I wake up more often, or if their PhDs show frequent arousals, they have a higher arousal index. The third facet is that many people have an unknown sleep-associated leg movement disorder called restless legs in sleep. And it is not necessary that every patient who has RLS will actually talk about RLS when they meet their doctor, because they don't know about it. So if you were actually to study elderly polysomnograms and treat the restless leg syndrome, their depth and quality of sleep improves. So from a GP's perspective, if someone has poor sleep depth because of frequent awakening, I think melatonin is better than other things to start with. If somebody has restless leg syndrome, then one could use either gabapentin or pramipexole. These are two approved medications for the treatment of RLS. It's somewhat related also to iron deficiency. So if they have iron deficiency, you got to correct them if you have picked it up in your geriatric screening in the health checks. And lastly, just the last 10 seconds is that many people who come and say that, doctor, I can't sleep. And in my experience, there's a large number, because I do a fair amount of sleep studies in elderly, is that they cannot sleep because they're hypoxic, because they have undetected sleep apnea. And they are not fat. Many of them are not fat at all. They are lean, much leaner than me and Ashish. They are sometimes a little retrognathic, and they have weak musculature. And this is the burden of geriatric OSA. If one looks at a recent French study from France and Switzerland, is almost 60% in elderly care facility. So many people wake up because they're hypoxic at night. So just correcting their sleep apnea, which is with a simple CPAP device, can help them sleep better. So I personally think I see ourselves meeting 5 years from now, Ashish, you, Dr. Preeti Sabria, Dr. Shah, and we should be having polysomnography as a part of our health check by that time.
Superb.
Your point is well taken.
And you'll be happy to know that after attending your sleep talk 3 years ago, I'm making it a point to try and achieve 8 hours every night, and I manage 4 or 5 nights out of 7. So that's certainly made a big difference. I've got a question for Dr. Shah, Dr. Ashutosh Shah. BPSD, the behavior and psychological symptoms in dementia, what would be your approach in addressing these, and would you be using antipsychotic therapy for this?
Okay, so though this term is in vogue, it's not the best of term, but world over everybody is using this term BPSD, behavioral and psychological symptoms, essentially to denote a disturbance of either thought or perception, mood or behavior. And a long list of examples: wandering, repetitive questioning, agitation, depression, apathy, and various socially inappropriate behaviors are covered under this rubric. Now, one of either of these symptoms is always likely to occur in any patient of dementia. So though cognitive symptom is the main domain, these kind of behavioral disturbances are the one which are most distressing to the family. And in fact, they increase the burden the caregiver burden, the burnout, risk of hospitalization, increase the morbidity, mortality. And in fact, what Dr. Preeti Chabria was saying about de-prescribing, in fact, there's a risk of having escalation of doses or addition of new medicines when these symptom complexes occur. And what Dr. Manish also said in his presentation, cost is a very sensitive factor. It increases the cost to the family when these symptoms occur. Now, by and large, usually there's a knee-jerk reflex. Okay, patient is agitated, give him an antipsychotic. That's not supposed to be done. So say, for example, a physician gets a call saying there's shortness of breath. They don't assume that this is pneumonia and prescribe antibiotic. So there has to be a systematic approach over here. And recently, the National Institute of Mental Health and National Institute of Aging in US, they have viewed this particular thing and given a conceptual model to say that all these disturbances are essentially occurring because of a brain circuitry dysfunction. So a slight bit of it was touched by Shraddha Shah in her presentation when she talked about default mode networks. There are more than 100 different circuits in our brain. These get disrupted, and as a result, the people are more vulnerable to three kinds of triggers. A, the patient-related factors, pain, hunger, infection, constipation. These can trigger these kind of factors. So the physician has to look and evaluate, are these present? So just take example of pediatrics. Children cannot express. Same thing happens in the geriatric population. They are not able to express what is going on within them. Insula is one area of the brain which is responsible for monitoring what is happening within us. And it's quite close to the anterior cingulate circuit, which Dr. Joy had said. So this is where the ability of the brain to monitor what's going wrong in the body is impaired, and the people are not able to vocalize it. So it's for the physician to figure out what is happening. The second factor is the caregiver factor. So over here, caregiver depression, often not recognized, can lead to a triggering of agitation in the dementing patient, or even unrealistic expectation. Sometimes people have not really understood that the person is not able to do XYZ task. They need to be informed, re-educated about what dementia exactly is, or they can have negative communication. And the third is environmental factors. So overstimulation. So viewing the mobiles, laptops, TV late in the night will interfere with secretion of melatonin, and that can also cause insomnia. Or even sometimes limited exposure of light during the daytime. This will derail the circadian entropy which is there in most of the individuals. So there has to be an approach, a systematic approach, and that is acronym DICE, D-I-C-E, as in describe what's going wrong. So first of all, a thorough history taking, contextualize what was the abnormal behavior, what triggered it potentially. If there is no risk of immediate self-harm, do not give anything. First, investigate. So in that investigation, the same approach I said about patient factors, caregiver factors, environmental factors, then create a plan. So maybe a non-pharmacological treatment plan whereby these things can be rectified. And finally, if there is identified that the person has depression or has psychosis, then give the lowest possible dose of an antipsychotic or an antidepressant with the least anticholinergic side effect to begin with, and then evaluate. So last part is to evaluate if a medication was started, what was the response? Were there side effects? Were there other non-pharmacological methods implemented? And then keep evaluating the patients on an ongoing basis. So this is answering the first part, the approach to BPSD. In terms of antipsychotics for management, there is no blanket yes or no. We have to follow this approach. So it avoids irrational prescriptions in a patient. And then antipsychotics are the only class of drugs which have shown to have an efficacy in treating BPSD, even if it's a modest efficacy. So international experts have recommended low dose of risperidone, which has less anticholinergic side effects in managing when every other option has been exhausted. And antipsychotics have been used to treat BPSD right from 1950s. The trigger came in 2005 and 2008 when the US FDA gave a black box warning saying there's increased mortality linked to use of these. But of course, this is when it is used injudiciously. And what happened thereafter was many other psychotropics, which were not antipsychotics, were prescribed, which had a sedating action. And in fact, these also increase mortality. So use of mood stabilizers like various anti-epileptic drugs increase in the US. but there is no data to say that they have any efficacy. So antipsychotics can be used, but start low and go slow.
Can I say a word here, Ashish?
Sure, please.
Yeah. So one of the things we forget is that it takes only 2.5 or 3 days of insomnia, sustained consecutive insomnia. Don't sleep for 3 days. Your brain can become psychotic even if you don't have cognitive impairment. And we don't emphasize this when we talk about physiology. So it takes only 72 hours of serious sleep deprivation to desynchronize our reality perception of the brain. So obviously, in a senior person, if there is constipation, there is a little cognitive dysfunction, they have not been sleeping well, they're going to exhibit behavioral problems. And what Dr. Asutosh said is correct. We need to holistically understand what are the factors that are leading to it, rather than ad hoc prescribe some medication like quetiapine or olanzapine or whatever we think is a dopamine blocking agent. So I would resonate with what he has said. I think we have all these factors need to be taken into account.
So I think the moral of the story is have a complete assessment, and I'm sure Dr. Preeti will be happy with not just adding polypharmacy without the full assessment.
Yeah.
Dr. Jitesh, Dr. Anil, can we go for 10 minutes more because we started?
Yes, yes.
Is that okay?
One word, Dr. Contractor?
Yes.
Benzodiazepines, please avoid in the elderly. I mean, almost our entire geriatric population is hooked onto it. And I think that's something which can be prevented. Do not give benzodiazepines for insomnia in general, and definitely not for geriatric population without evaluating the cause.
So there is some good news on that front. In all our 30 years of being physicians, we have been using a benzo to induce sleep because we know that there are the activating neurotransmitters and the suppressing ones, and the suppressing ones are GABA. So pharmaceutical industry developed GABA modulating medications. Now there is lemborexant. Lemborexant is a dual receptor modulator for orexin. Orexin is our wakefulness neurotransmitter. And lemborexant is going to be launched in India very soon. And there is a melanocortin receptor modulator also, which should be available in our market soon. So there are 2 new drugs for insomnia, which are probably far more geriatric physiologically friendly than what we have in our armamentarium. And maybe next year when we're doing Alzheimer, things will be better off.
There's one question. This is regarding overactive bladder, because what I read is most of these drugs which are used, like oxybutynin or solifenacin and all those, they have some effect on the dementia. So which drug is safe? Like, we can use it. Hello?
Yeah.
Can you hear me? Hello?
Yeah.
Yes, Dr. Anil. So who would like to take the question for the bladder?
Is Dr. Preeti want to do that, or Dr. Arun was to others? I'm happy to jump in.
Yeah.
Go ahead.
So, for us, the standard medication is an alpha blocker that urologists prescribe for people, for males with benign prostatic enlargement, and even for women with hyperactive bladder disorders producing nocturnal frequency. The downside to usage of alpha blocker is that it often produces postural hypertension in elderly people. And here I think Dr. Preeti will resonate that many of our patients who we see who are dizzy, they're dizzy for a few seconds because they have postural hypertension. And at a GP level, we should examine their blood pressures when we assess them for dizziness, rather than give them Vertin or give them Cinnarizine for perceived dizziness. And there has to be an understanding that it could be drug related. So her question about polypharmacy, and the other small facet which we don't know and which is often not discussed, but which is there, the respiratory docs know that, is that if you have untreated sleep apnea, then it produces polyuria at night. So you don't make so much urine in the day, but you're making more urine at night. And since I have an interest and I listen to patients and I've been now seeing them, many a time you find that you have someone with OSA who's been treated with CPAP. They are no longer waking up 5 times, even though their prostates were treated. So there are many tenets to understanding the fluid balance in day and night. And maybe Dr. Preeti also should.
To add to your very correct answer is that we also make a push for the non-pharmacological therapy before we jump into medications. The first thing is to ask them to quit their liquids after 8 p.m. And the first answer to that will be that, oh God, doctor, I have so many medications to take at night. And then we have to remind them it's okay to take it a little earlier with just a little sip of water and try that non-pharmacologic therapy. So our basic goal has to be to try to minimize medications for a short period of time. The goal is not to stop medications, but to try to use other modalities for as long as we can, just to prevent this growing burden of medications.
Yeah. The other thing is a very small point, which is relevant, is that if you look at all our patients in middle life, we tell them, okay, you need to be exercising. So the doctor said, "Su karwano." So you say that walk every day. But we've got our middle life patients. We've got to encourage them to do core exercises. It's if they do core exercises, they have a good pelvic floor. And Ashish will resonate with me here. If our middle life patients are doing regular core exercises, their pelvic floor is more toned, especially women. They are much less likely to have a great deal of nocturia at night because their urogenital systems are behaving better.
Very true. And you'll be happy to know, Dr. Desai, we started a very active pelvic floor rehab in our department as well, both bladder and bowel rehab. I've got a question for Shraddha. Shraddha, what is the role of pets in this whole? And I know that your pet has given you a little bit of grief today. So what is the role of pets in for mental health, for people as they age? I've been reading on that as well. So I thought this is a good time to ask the question.
Oh God, I apologize on her behalf.
No,
First and
that's
foremost.
perfectly fine.
Specifically for geriatrics, there is very limited data from what I understand, except for when there is an illness. So if we're talking about stroke rehab and we're involving animal therapy, or if we're looking at even dementia, but from a rehabilitative perspective, animal interventions and animal therapy has shown to be very, very helpful. In India specifically, I think we don't have enough animal therapists. We do have a team here in Bombay who do very good work. They work more with the autistic spectrum. They don't do as much work, I think, which is with everything else, like the geriatric population. So there aren't enough people working with the geriatric population. But the amount of reading that I have done, I know that there are beneficial effects, but I would have to get back to you with specific studies about it.
Thank you. Thanks, Shraddha. Maybe we'll have 2 or 3 more questions and then we can wrap up.
Yeah.
Dr. Manish, your talk was on COVID and dementia. So a lot of post-COVID patients also come to us, and we read in sort of layman terms that many of them have this brain fog kind of symptoms where they're just not themselves. So in your opinion, from a practical point of view, when do you think that they should be assessed? I mean, what level of, if I might say so, symptoms, or what would be your sort of red flags where you would want someone to have a formal neurological assessment post-COVID?
As we have seen that post-COVID, as I mentioned, patients coming out from ICU or severe COVID, they do have a certain degree of cognitive decline. But I would say once they're in the ward, once their metabolic derangements have settled down, and once they are not in that acute phase, that is a time we can start assessing, or on the first follow-up. once they have totally recovered. That is a time we can assess their cognitive domains and see where they are lacking. And important is to talk to the family. What was the pre-COVID state? What was the state before the acute illness happened? And our aim should be to try to reach to that baseline with periodic assessment. But I would say post-discharge on the first follow-up, we can assess their cognitive domains and then take it from there.
Okay, thank you. So I think it's nearing 1 o'clock and it's probably time for people's Sunday lunch as well. So I'll ask Dr. Arun Shah the last couple of questions. Dr. Shah, someone had asked, do you see dementia at all? Sorry, not dementia, Alzheimer's in a young or adolescent population, especially if there's drug abuse? That was the first question. And the second one I'm going to ask is a question that's been posed by a participant. What's the difference between simple memory loss due to aging, dementia, and Alzheimer's disease? And if a patient mentioned the same points again and again during a conversation, is that a warning sign?
Let me answer the second question first. I think one of my slides, there are two slides which I think block of time I didn't show. To differentiate between what is normal age-related memory impairment versus memory impairment in dementia or MCI. I think the question is, as we mentioned, at the age of 60, 65, and I am facing myself some retrieval difficulty. You need a cue, and with cue, everything becomes very clear. While a person with Alzheimer's will never be able to, even if you give cue, maybe he will say no, he doesn't remember. Second, most important point is the visuospatial difficulties. All that generally does not occur with age. I think all those abilities remain intact even at the elderly people. I don't think they forget that. And I use a criteria, or somewhere I read, and I don't know if it's substantiated. If somebody repeats more than 6 facts a day, consider it as abnormal. Up to 4 or 5 repetitions are okay, but if somebody repeats 4 to 5 or 6 facts a day or so, then maybe things are not proper. And of course, inappropriate behavior also is not considered as normal aging. So I think not very difficult to differentiate between age-related memory impairment versus Alzheimer's dementia. Will follow certain rules, I think. So only MCI and this, there may be sometimes gray line between MCI and normal aging sometimes. But if you do a formal evaluation, maybe things become very clear. And in certain cases, we do ask for formal neuropsychological tests when we have doubt whether this is just normal age related because of preoccupation, anxiety. I think sometimes you do see forgetfulness because of all the other things which is going on in life. So that is as far as the second question. And may I ask the first question was about?
They were asking about, do you see this in adolescents or in younger people?
No. Yeah. I don't think so. I think it's very clear that if you see somebody who has cognitive decline and or a dementia by our defined criteria below the age of 60, 65, you cannot say it is Alzheimer's, except for those rare genetic disorders where you will see early onset. So if you see there, I think you need to work them up properly to find out a reversible cause or an autoimmune etiology or a slow virus disease or something else, which probably we are missing, or maybe HIV related or something else. I don't think we can make diagnosis of degenerative dementia at the age of 40, except for people who have genetic mutations.
Okay. Thank you so much. So I think it's been a wonderful and a healthy panel discussion, a lot of participation. I'm going to now hand over to Dr. Arvind Patel. He's the Joint Honorary Secretary of the IMA for the formal vote of thanks. Dr. Patel.
Yeah, Dr. Patel.
Thank you very much.
Dr. Patel, 1 minute before you give vote of thanks, I would like to say that Dr. Shraddha Shah has been, apologizing for the barking off and on, but I feel that as per the law of his master's voice, the dog also was appreciating such a wonderful lecture, one of the best lectures that we had today. So I feel that, no, Shraddha, you should not do that. It was a fabulous lecture, even your doggy like that. Thank you very much. I hand over to Arun.
That's very much characteristic of our secretary, Dr. Girish Lad. He always thinks and sees positive things in any situation. Always makes things positive.
And
that's a good neuroprotective skill.
Thank you.
Before we go on to the vote of thanks, again, I just want to share one small presentation. It is about why you should become a member of IMA. And I request all the panelists who are not member of IMA, they should also become a member of IMA. IMA basically is the largest and the fastest growing non-government NGO of over 2.5 lakh healthcare providers. We have around 1,800 branches all over India. And these are some of the benefits you can avail if you are IMA member. This is the, like, you can get credit R points. Then we have our medical legal help for all our members round the clock. We have a professional protection scheme, maybe up to 10 lakhs at a very nominal fees. We have a magazine, Bima, where you can put your whatever, if you want to put any lecture or something, you can do that. We have a social security scheme. We have a guest room facilities. We have a IMA hall in Mumbai with a lawn where we get a 5% discount for IMA members. We have some discount on the purchase of car. And of course, the last one is the membership is transferable to all over India. So do become member. Those who are member, they can tell their friends to become member of Indian Medical Association, Mumbai branch. Thanks a lot.
Thank you, Dr. Awad, for that.
Good afternoon. Am I audible?
Yes,
Yes.
Good afternoon to all of you. We remember their love when they can no longer remember. Thank you very much for allowing to propose vote of thanks. Our big thanks to our esteemed speakers, Dr. Arun Shah, Dr. Joy Desai, Dr. Manish Chabria, Dr. Preeti Chabria, Dr. Shraddha Shah, Dr. Ashish Contractor, and Dr. Ashutosh Shah. We thank our knowledge partner for this webinar, Sir H.N. Reliance Foundation Hospital and Research Center. We thank Mr. Dipan Mehta, Mr. Piyush Kade, and Mrs. Vaishali Tanpure from DigiShield for providing us digital platform and technical support. We thank Dr. Anil Awad for conducting and coordinating this webinar efficiently, of course, as usual. We thank Dr. Pankaj Bandarkar for being MMC observer for today's webinar. Today, we have more than 500 attendees. So thanks to all the delegates for participating in this webinar in such a large number and making this a grand success. Have a great day. Thank you very much.
Thank you.
Thank you. Thank you all.
Thank you all.
Thank you.
Thank you, everyone. Thank you very much.
Thank you.
Bye-bye.
Piyush?
Yes, sir.
Close.